saya reality no mean to me near she it more cram into me as I said some it take you 2 weeks 3 weeks sometimes 1 month and in a muja to me ya and I do would be with fibroid yet better yarian and so we call baby almost say I just operation and I'm in to Mr. Baby I say as son you know and I'm this year me mammy dear friend mama Elizabeth and now oh mammy a globia your friend Tigo Ben into 3 months me shall say no because hospital no almost say fibroid a 4 now so me share do not say no 3 months me miss call send me for checking it because check up no almost say I can't carry me that you me say and I'm in me person me operation me person me koswa enum sa Tigo Ben na me sure say yeah there ya me betumi aboa me amani na
Welcome and thank you for joining us for the day 2 of the Premier Uterine Fibroid Africa Conference. My name is Dr. Davison Mnodawafa, and I'm pleased to bring to you greetings from the city of Gweru, Zimbabwe. I will again serve as your moderator. And now joining us from Germany is Ms. Tancha Hohenstar, a micronutrient coach and nutritionist. Her Chogivit green tea capsule have been approved for clinical trials for the treatment of uterine fibroids at a women's hospital in Berlin.
Hello and welcome. I give you a presentation now about how to shrink fibroids. Can natural remedies help? 99.2 million reported cases of fibroids in women aged 15 years and above worldwide. I think this is a pretty number to take into consideration, right? Hello, my name is Tanja Hohenstar. I'm from Germany. And a few years ago, my gynecologist, she had diagnosed me with a rapidly growing myoma. And instead of surgically removing it and starting hormone treatment, I decided to more on a natural route. I came across green tea, which is a highly valued in Asia. And in a study in women, it had a positive effect on the growth of myoma. And after my illness and the discovery of the great treasure of green tea can represent for us, I knew that I had found basically my soul mission, my life project. This is Tigobit green tea capsule. Many women are desperately looking for a naturopathic option to prevent fibroids. The successful self-experiment was the spark that gave me the idea for my business. The green tea extract we used in our product, in our green tea, Tigobit green tea extract capsule, come from a controlled organic cultivation, and it's free from pesticides or heavy metals. And as you can see, I'm frequently traveling to China because I want to check the direct organic green tea garden, because the quality of my product is very important for me. And before going into any new production, the extract of the green tea will be tested of heavy metal and pesticides. And this is with German laboratories. In addition, this product is free from any fillers or any flow materials. Tea was medicine first, and it became a drink later. And green tea is much more than a drink, and over the centuries has become an indispensable part of the traditions developed in Asian countries, and not only in terms of gastronomy, but also in the means of preventing any and treating disease. So far, more than 300 different substances has been found in green tea. And in addition to vitamins, minerals, proteins, the green tea plant also contains other herbal compounds that protect it against viruses, for example, and harmful viruses and bacteria. And the most important herbal protective substances in green tea are the catechins, which belongs to the group of the plant of the polyphenols. And catechins give the tea its bitter taste. And the power of EGCG in green tea. So EGCG means the epigallocatechin 3-galate. And the most interesting catechins are the epigallocatechin 3-galate. It's a very, very difficult word to pronunciation, especially in English. So, which is found in particular high concentration in the leaves of the green tea plant. EGCG is coming more and more into the focus of science, and it is a very well tolerated substances for humans. EGCG may support oxidative stress and inflammation. It may support and protect the brain. So supports health, metabolism, and weight loss, and may support health, women health like fibroids, endometriosis, and of course, wish for a child. It may lower the risk of some cancers, may support heart health, it may support antiviral and antibacterial infections. And is pretty impressive for a natural compound. Don't you think so? But also the questions, what we asked ourselves in Germany was, does EGCG improve the quality of life of women with fibroids? The development of myomas of fibroids, where the most scientific work has been done, EGCG is certainly interesting as a simple, preventive, and also a component. Does EGCG improve the quality of life of women in fibroids? And we did a clinical user observation with our product at the university in Berlin, the Charité. It was in January 21. 2 years ago, the Berlin Women's Hospital launched a study to investigate the effects of green tea extract on the quality of life of women suffering from fibroids. We had 30 women took the green tea capsules Tigovit 3 times, 6 months, and were examined by physicians after every 3 months. And the results, the growth of the fibroids, some fibroids of the women's have become smaller. Others have remained stable. And a few very small have become larger. If in any case, there was no negative side effects or any negative effects, and no side effects, and because it's a natural substances. And most important, the quality of life. Most women have found a better quality of life, mobility, and physical awareness. And Professor Chalit Sihuli, he's the head of the Women Clinic Charité. The response was great, and we're excited to have more than one other option for fibroids treatment now. Personally, I consider this study with green tea extract a success. And so now I have a lot of more confidence, especially as a doctor, to talk to patients about green tea extract in context of health and prevention. But green tea drinking is not enough, unfortunately. It's sometimes so easy to think about, but One capsule of Tiguvit contains, for example, 170 milligrams of EGCG. And this is about 4 cups of green tea. And usually the recommended dosage of the 3 capsules contains 480 milligrams, which is about daily 12 cups of green tea. But drinking green tea, like I told you already, it's not enough, because EGCG is the polyphenol and the catechin in green tea, and it has a very low bioavailability. So drinking green tea is not enough because there is too little intake of EGCG, and EGCG is metabolized very quickly in the body, and it's not sufficient for our Western tea drinking habits, because since we are more a coffee nation than a tea drinking nation, for example. And as you can see on my presentation, because usually if you're drinking green tea, a freshly brewed green tea, it has like 300 milligrams of EGCG. But when you drink green tea, you need to pass the stomach, it needs to pass the gut, the liver, and the blood. And until it comes to the blood serum, it's very little of EGCG in the bloodstream over. That's why you have to take it in a higher concentration. So it's better to take it as an extract and as in capsules. Drinking green tea is not enough for Western culture habits, because in Asia, for example, people drink more than 1 to 2 liters, very high quality of green tea. And green tea, like I said, it's usually better to take it as a capsule, like an extract we have it. Because, however, sometimes we are busy due to circumstances. They are at least able to drink 2 liters green tea every day. We are traveling, we're at work, we're doing sports, we're doing shopping, and we are not always able to brew our fresh green tea. And we simply cannot constantly make the high quality of green tea. And I researched the topic of green tea for many, many years now. And I came with an all-around successful concept, and I have put it all together in the simplest form, which is Tiguvit Green Tea Complex. To improve the bioavailability, we from Tiguvit use bioperine. This means pepper extract, and this is in a high proportion of herbal substances. And I use vitamin C to stabilize and value the components of the green tea. And this makes Tiguvit absolutely extraordinary and unique. Like as I told you before, 1 capsule of Tiguvit contains 4 cups of fresh green tea. What I also have done, 2016, I developed my company specialized on green tea capsules with Tiguvit, and I am now in Europe. I am in Germany, I'm in Austria, in Switzerland, where a lot of gynecologists are using our products and recommend it to their patients. And I have 2018, I made a partnership with a green tea garden in China, where I regularly usually fly there and take the best extracts for our green tea capsules. In 2018-19, we had the clinical observation study at the university at Charité. In 2019, I developed a new product, which is Tigusol, which is a vitamin D product with a probioticum. And of course, Tiguvit goes around the world because we are happy to help women and make women a better life and to improve the quality of women's. And we established our partnership, for example, in the Middle East. We established our partnership in Europe, in Portugal, and also, of course, in the US market. But the last one in last year, I developed a new skincare product also with green tea, because also we women want to be looking nice. So that's why green tea also is super and very helpful for our skin. And who wants to, let's stay in touch, and who wants to get in touch with me, here is my details, my Instagram account. You can connect with me. Here you will find my telephone number. I'm always available on WhatsApp. So if you have any questions in regards of our Tigovit, or if you need any nutrition information, please let me know. So thank you very much. It was a pleasure to have this presentation, and I'm happy when I will be staying in touch with you. Thank you so much.
Thank you, Ms. Hoffenstar. I now introduce Dr. Ayem Al-Hedi, a gynecologist and endoscopic surgeon at UC Medical Center, Chicago, Illinois, with a busy practice that focuses on serving women with symptomatic uterine fibroids and premature ovarian insufficiency.
Hello, everyone. This is Ayman Al-Hindi. I'm a professor of OBGYN at the University of Chicago, and it's a pleasure to be with you today. I would like to thank the individuals that made this great conference a reality. I particularly like to thank Ms. Liz Cora from African Fibroid Foundation, Africa, and also our very own Miss Lillian Prince, hopefully soon to be Dr. Lillian Prince. She is our wonderful PhD student, for all the effort they put to put this conference together. And of course, I would like to thank Dr. Phyllis Lippert and the Campion Fund for supporting this important event. I'm really excited to participate in this, and I hope this will be a regular annual event, so we can continue our collaboration with our colleagues in Africa to try to combat uterine fibroids in Africa and worldwide. The title of my talk today is Natural Compounds for Prevention and Treatment of Uterine Fibroids, and I'm going to focus mostly on green tea extract. These are my disclosures. So the objective of my talk, I'm going to start with some introductory remarks, and then just an overview of the treatment of fibroids. And like I said, I've been asked to focus mainly on a green tea extract, or EGCG, epigal-catching gallate, and uterine fibroids, and we'll finish with some future direction. So in terms of uterine fibroids, I'm sure other speakers would have covered that, but as we know, it's a very common tumor of the wall of the uterus, very common globally, but particularly more prevalent and more severe in women of color. And it has a major negative effect on women's quality of life, and a cause of major morbidity, and also a lot of surgery, normally or usually in the form of hysterectomy, but also other procedures. We published this paper with Dr. Prosper Igoboli from University of Nigeria a few years ago about the fibroid burden in Africa, all over Africa, but this particular review article focused on sub-Saharan Africa. And this is a picture of one of his patients that he cared for at the University Hospital in Abuja. And as you can see, this was a significant disease burden in this particular patient. The interesting things also I came to know interacting with my colleagues in Africa and actually visiting different hospitals in Africa and Egypt and in other countries, that beside all the clinical manifestation of fibroid, also it has some social impact, because as you can see in this particular patient who is very thin and with such a big fibroid disease, she had this significant bulge in her abdomen. She actually looks like that she might be pregnant. And in some close communities, if this patient happened to be, let's say, unmarried, this actually might cause a lot of social stigma and additional stress for this patient beside all the clinical manifestations that we are all familiar with. I also wanted to include this figure about the number of publications related to fibroids from different countries in the world. This is a paper from 2018, so at least up to that point, these are the numbers. And as you can see, overall, the numbers of publication basically reflecting the amount of research done in the area of fibroids is rather limited, but even more impressive that the highest countries publishing these papers, the United States were the highest, and then certain countries in Europe, but unfortunately, very few papers coming out of Africa, which is kind of compressed here in the lower part of the figure. And I hope this conference and other initiatives can change this. I also wanted to impress upon you that fibroids actually started in Africa. This is a picture of a calcified fibroid from an Egyptian mummy about estimated 5,000 years old that was discovered some time ago, but then further analysis of DNA was published more recently in 2017. Just to impress upon you that fibroids started in Africa and also still quite common and almost pandemic level in Africa. And I hope, again, that we can work together to change that. We know from our work and many others that fibroids are more common in women of color all over the world. In the United States, for example, they are much more common in African American compared to European American, and also more common in Hispanic compared to European American. They start early, quite early, in late teen years in women of color, much earlier than their European counterparts, and also continue to significantly increase compared to other ethnic groups. And also the disease burden as far as the number of fibroid, the size of fibroid, and of course, consequently, the number of hysterectomies, for example, are much higher in women of color in general compared to other ethnic groups. We have published this review article just a couple of weeks ago, an endocrine review, trying to dig deeper into why this is, why fibroids are more common in women of color. So because of the time constraint in this conference for my presentation, I'm not going to go into details, but I would really like to invite you to look into this. As we, in this review article, we covered comprehensively the different factors that can be contributing to the health disparity of this disease. So how do we treat uterine fibroids? Generally, I would say, like any other disease, we have medical treatment options, surgical treatment options, and then some procedures such as uterine artery embolization or MRI-guided focus ultrasound. But unlike other diseases, until recently, the main treatment options that have been actually exercised and established themselves as the mainstay has been surgery, typically in the form of hysterectomy. In the United States, for example, we do more than 600,000 hysterectomies every year. Many of those are due to fibroids. We do also myomectomies and other procedures. But with the recent development of several FDA-approved safe and effective long-term treatment options for fibroid, I'm hoping and speculating that the paradigm will shift towards medical therapy and less on the surgical side, which is a welcome addition and welcome change anywhere in the world. But I would say particularly in low resource countries, this particularly will be an important shift. So what are the medical treatment options against uterine fibroids? Again, for the sake of time, I would not cover every aspect of this, but generally we can divide those into non-hormonal versus hormonal. And non-hormonal are usually natural products, while hormonal in this list are all synthetic products. Our group has contributed significantly to the development of several of these recent hormonal additions, such as elagolix, ursodeoxycholic, linzagolix, and some of this work has been published. So if you're interested in this, I would encourage you to check out these papers in the literature. But for today, I'm going to focus particularly on the utility of green tea extract, or the active ingredient there is called EGCG, epigallocatechin gallate, for the treatment and hopefully also for the prevention of uterine fibroids. The way actually we got into this many years ago, so about 14, 15 years ago, we were actually trying to understand again why fibroid is more common in women of color. And because we know that fibroids are estrogen progesterone dependent in a way that estrogen and progesterone cooperate to actually enhance the growth of fibroid and make fibroid bigger. We wanted to take a genetic approach and look at genetic polymorphic markers distribution between African-American patient versus European American patient, as far as different genes and receptors involved in estrogen signaling. So we looked at estrogen receptor alpha, estrogen receptor beta, progesterone receptor, aromatase, which is an enzyme that makes estrogen convert testosterone to estrogen, and then COMT. To make a long story short, we found a significant association between polymorphic markers in ER alpha, estrogen receptor alpha, and COMT, and the different ethnic groups in women suffering from fibroid, but we didn't find association in the other genes. And that's how we got to know about the COMT story. So what is COMT? COMT, the full name is catechol O-methyl transferase. So it's an enzyme involved in the breakdown or the catabolism of estrogen. So this is the forms of estrogen in the human body, mostly in the forms of estradiol, some in the forms of estrone, which is a weak estrogen. Then after the estrogen binds to the receptor and do its work, then like any other compounds in our body, it needs to be broken down or metabolized, if you wish. And the estrogen goes through this cycle. Eventually, it will be methylated using COMT into methoxy products, okay? Now, the estrogen breakdown products or metabolites turn out to be actually hormonally active. They are not inert products. They are actually hormonally active. And in such a way that the methoxy estrogen products are actually quite estrogenic, quite active, actually even more than the natural compound or the parent compound, while the precursors of those are anti-estrogen. So in such a way that the more COMT activity you have, the more estrogenic milieu you will have in this particular cell or in this particular tissue, because you're going to have more of the methoxy metabolite. While vice versa, if you have low COMT activity, you will have more of the anti-estrogenic activity, and the estrogenic milieu in this tissue will be low estrogen or anti-estrogen. So because of that, we were very interested in the polymorphic markers on the COMT gene and its association with different ethnic groups. And sure enough, we found that the high activity, the high enzyme activity allele or genetic marker, the VAL comes from valine. Valine are actually associated with higher COMT activity, and they are much more common in Black individuals or Black women. So that suggests that Black women in their body milieu, particularly in the myometrium, will actually have more estrogenic milieu, which again is consistent with higher risk of developing fibroid. While white or European American women actually had very less frequency of the VAL and more common of the counter allele is called the methionine, which is associated with low estrogenic milieu. So this was all consistent with our understanding of the pathophysiology of fibroid, and we published that several years ago. But this actually got us interested in the COMT gene in general, and what does it do in terms of causing fibroid and enhancing fibroid growth. So we first started with simple stuff about the expression, for example, of COMT in fibroid versus adjacent myometrium. And as you can see here for the immunohistochemistry about the protein expression of the COMT gene, it's much higher in the fibroid compared to adjacent myometrium, suggesting that it is important in the pathophysiology of fibroid. I'm kind of jumping over a lot of data because it's already published, but it turned out that all data suggested that COMT is actually enhancing fibroid growth in such a way that if we can inhibit COMET enzyme activity, we would actually have some benefits in killing fibroid cells and then eventually shrinking fibroid tumor and improving symptoms associated with fibroid. So we start looking for agents or compounds that actually can inhibit the COMET gene. And we found in the pharmacology literature that the EGCG, green tea extract, are very potent COMET inhibitor. So we were quite excited about this because it's a natural compound, easily available, inexpensive, and then we were also speculating that it would be safe. Most natural compounds are safe to use with limited or no side effect. So we were very excited that there is a natural COMET inhibitor, and we wanted to evaluate it further. So we jumped on this right away. We start to use different COMET inhibitors, the EGCG and other COMET inhibitors in the lab first to see if it actually can inhibit the growth of fibroid cells. And here you actually see that estrogen enhances fibroid growth. This is fibroid cell proliferation, while different forms of COMET inhibitor significantly limit and inhibit fibroid cell growth. That was quite encouraging. We wanted to kind of dig deeper to know exactly how does that work. So we found that the EGCG causes apoptosis or cell death, programmed cell death in fibroid cells. And as you see here in this figure, also it caused some genetic changes. For example, in this case, it decreased the expression of BCL2, which is anti-apoptotic gene, meaning it activates apoptosis, again, enhancing cell death in human fibroid cells. We also did some global genetic profiling for cells treated with EGCG or the green tea extract versus placebo. And we can see that the EGCG actually works through multiple pathways, not only through inhibition of COMT, but also it has very strong anti-inflammatory effect. It also have anti-oxidative stress effect, etc. So that was all good news and encouraged us to go further. So again, here we characterize the genetic gene changes and expression of different genes after treatment with COMET inhibitor. And we can see that when we add the COMET inhibitor here, genes involved in cell proliferation, such as cyclin D1, are downregulated, meaning the cells are not proliferating as actively. Again, BCL2 and BAX, apoptosis-related genes, are altered in such a way that apoptosis is activated or cell death is activated. So all of this actually encouraged us to go further. And what do you do next? You evaluate this potential therapeutic agent in animal models. So we tested this first in a nude mice model where you develop a fibroid lesion under the skin. So it's kind of a human-made animal model. And as you can see here in this square, these are the fibroid lesion. And with the group treated with the EGCG show growth arrest and very slow growth versus the placebo, that tumor grow exponentially. And here's the numerical results after 4 weeks or 8 weeks, a significant shrinkage of the fibroid in the EGCG treatment group. And here's also additional gene expression of PCNA, which is the gene reflection of cell proliferation. You can see much less cell proliferation in the fibroid in the treatment group with EGCG versus the control group. And this work, again, has been published earlier. Then we wanted to even validate this further into another authentic animal model of fibroids called the rat, where the fibroids spontaneously develop in the animal model. So it's not human-made, it's actually a spontaneous fibroid. So it kind of resembled the human situation more closely. So we tested the rat in a similar fashion. And again, you can see here in the placebo-treated rats, fibroid continue to grow significantly over 4 weeks of treatment, while the group treated with the COMET inhibitor immediately stopped growing and actually gradually shrinking. This again was very encouraging, and this is an example of a tumor before treatment, and then at the end of the treatment 4 weeks later, and you can see much significant shrinkage in the Ecarat fibroid treated with green tea extract. So this all really encouraged us to go ahead with a clinical trial that we were very happy and grateful to the NIH for fund this trial a few years ago, where we treated about 80 patients with uterine fibroids, about 40 in the placebo arm and 40 in the green tea arm, where they received 800 milligram of EGCG orally in these capsules every day. And again, this is published. I would encourage you to go there for the full details. But briefly, we saw a significant improvement in the green tea treated group. For example, here's the fibroid volume. We saw about 33% shrinkage of the fibroid as assessed by ultrasound after about 6 months of treatment with EGCG, while the placebo-treated group actually continued to grow and gained about 24% increase in fibroid volume. Here we looked at the symptom severity using the validated quality of life questionnaire for uterine fibroids. And as you can see here, the green tea treatment group saw significant decrease in the symptom severity, about a decrease of about 25 score points, while the symptom severity actually got worse in the placebo group over the 6 months, and they gained about 7 points in the score, in the symptom severity score. Quality of life, the same way. Quality of life improved about 20 points in the green tea treated group, while it was more or less static or stable in the placebo group by increasing only 2 points. So all of this was very encouraging results. As I said, we followed these patients by transvaginal ultrasound, and this is just an example of a patient with about 3 centimeters by 3 centimeters intramural fibroid here. And you can see here after 6 months of EGCG treatment, the fibroid actually totally gone. So this actually encouraged us, especially as I said, natural products such as EGCG is quite safe and inexpensive. And the safety profile, by the way, the NIH trial we did in 2013 was outstanding. We only had mild gastric irritation, which actually went away when the patient used the EGCG on after a meal, like on full stomach. So basically the safety profile was outstanding. This encouraged us to go into evaluation of this in another group with fibroid, but also infertility. So this is an ongoing study based on the fact that the fibroid decreased fibroid volume, that the EGCG decreased fibroid volume, but specifically it actually changed the secretion profile, the cytokines and the different factors that comes from the fibroid that might negatively affect the endometrium and make the endometrial receptivity unfavorable for embryo implantation. We found that the EGCG is able to inhibit the production of TGF-beta-3, tumor growth factor beta-3, that from the fibroid, and from literature, from other groups, TGF-beta-3 can actually have negative effects on the endometrium. So the working hypothesis here that the EGCG not only will shrink fibroid, but also will improve the quality of the endometrium and presumably improve the chance of successful embryo implantation. So to check this hypothesis and validate it, we are doing an NIH-funded study in collaboration with other centers, Yale and Hopkins, to evaluate we call it the FRIEND trial, to evaluate the utility of EGCG for treatment of unexplained infertility in women with fibroid and unexplained infertility. This is an ongoing study. This is the general design, and I'm hoping next time we meet, I'll be able to present some data from this trial. So this is the end of my data slides. I just want to end in terms of future direction by saying that because of these encouraging results, using a simple, inexpensive, and safe natural products such as EGCG, green tea extract, and now we can actually think about the concept of early treatment and also the concept of prevention of uterine fibroid. because data from our group and others, we actually can predict with good amount of certainty who will have higher risk of developing fibroid. We have genetic markers. Also in other work we did, we published that low level of serum vitamin D is a risk factor for development of fibroid. This work has been validated by many other groups. So we are able to identify patients actually before they develop fibroid, pre-symptomatically, or at least very early in the disease journey. So, so by identifying those patients, I'm hoping using these kind of simple natural products such as EGCG, green tea extract, and also vitamin D. I didn't have time to present data on vitamin D. We can intervene early to prevent the progression of the disease, or even intervene even earlier and prevent the development of disease. So this is my last slide. I would like to thank, of course, the wonderful members of our team who contributed to this work. They are mentioned here on the slide, and our collaborators in the US and elsewhere, and of course, funding by the National Institute of Health. Thank you so much for your listening, and I'm happy to answer any questions.
Thank you, Dr. Al-Hedi. Next, we will hear from Dr. Charlotte Tinchet Nguefak, who is Chief of the Obstetrics and Gynecology Department of Douala General Hospital, DGH, and attached to the medical department responsible for mother and child sector at DGH. She is also Vice President of Cameroonian Association of Minimally Invasive Surgery.
So Douala is a region, a littoral region of the Cameroon, and we work in this hospital, Douala General Hospital, which is the first level hospital in Cameroon. So uterine fibroids, also called uterine leiomyomas or uterine myomas, are benign smooth muscle tumors that develop in the myometrium. They are the commonest pelvic tumor in the woman, occurring in about 20 to 25% of women over the age of 30. Uterine fibroids are remarkably common in blacks, but only a subset of women have their fibroid clinically detected. Sometimes they may be revealed by complications like infertility, anemia, necrosis, urinary symptoms, constipation. Fibroids are also the most common indication for hysterectomy in our practice. So some recalls, just to say something about the anatomy of the uterus. Here is the uterus in a frontal coupe with the tubes and the ovary. The uterine fibroid will develop within the muscles of the uterus, like you can see here. Then we also know that physiologically, they develop in the relationship to the hormonal state, the influence of estrogen and progesterone that are secreted by ovaries that will favor the growth of the uterine fibroid. So this is a sagittal section of the pelvis, woman pelvis, which shows the relationship between the uterus and the bladder in front, the rectum behind, so that we may understand that some fibroid growing very big may compress these organs that are near the uterus. Here is histology recall, just to say that the uterus wall is divided in three parts. You have the endometrium, the myometrium, and then the perimetrium, which is the serosa. So according to the FIGO classification, you have 8 types of uterine fibroid. The FIGO classification is the classification that is now used for the uterine fibroid. And then you have submucosal fibroids, which are class 0 to 2 of 0, 1, and 2 of the FIGO classification. And then the intramural fibroids are class 4, 5, 6, 7, 5, 4, 5. And then you have the subserous fibroids, which represent the class 5, 6, and 7. And then you have others who may be cervical or parasitic fibroids. So it's just important because usually when you are doing some studies, it's good to have the same terminology around the world. Before, we were just saying subserous, intramural, and submucous. But now it's FIGO 1, 0, 1, 2, 3, 4, 5, and 6, 7. So saying that, we come to the epidemiology aspect. Concerning the frequency, we have already said that they are the commonest tumors, benign tumors of the woman at reproductive age. They occur about 20 to 25% of women over the age of 30 years, but they may affect up to 70% of women before menopause. They occur 3 to 4 times more in Blacks. It is estimated that 70 to 80% of Black women will harbor fibroids over their lifetime. So in Cameroon, it's very difficult to have the real frequencies of hospital, but we have found some hospital-based studies. Chente and collaborators did a study on 171 women with uterine fibroids. So the frequency was calculated over the total number of consultations at that period, and it was 4% in 2012. In the same team in between 2016 and 2020, another study was done. That was a case control study to compare women with uterine fibroids and those without. And we recruited 133 participants with uterine fibroids, over 6,676 patients hospitalized in the hospital during the 5 years period, giving the frequency of 6.5%. Egbe and collaborators studies the fibroid in pregnant women, and they have a frequency of 16.7% in 2018. So we can also find that the fibroids are frequent because they represent the most common indication of hysterectomy in our place. So in Cameroon, not many studies have been published concerning the frequency. So we are thinking of a project where we can have a portable echograph and going around in the villages and some towns and systematically do echography to have the real frequencies of this pathology in women. Concerning the etiopathogyny, for the pathogeny, you know that when compared with a normal myometrium, smooth muscles of women with uterine fibroid exhibit increased expression of steroid hormone receptors, growth factors, and growth factor receptors than those of women without uterine fibroid. So steroid hormone, estrogen, and progesterone played an important role in the development of uterine fibroid. So many studies have also shown that progesterone is playing a very important role. That's why there have some drugs have been developed for the regulation of the receptor of progesterone to reduce the increase of the volume of the fibroid. So other influence concerning the pathology include the genetic, the vascular, and fibrotic factors. In conclusion, uterine fibroid will develop according to the modification of hormone, estrogen and progesterone and its receptor, along with the genetic factors. So this is a study that has been done in the United States. We show that not only we have estrogen and receptors as element of pathogeny, but we also have some nutritional factors like the decrease in vitamin D, which increase the risk of uterine fibroid, which plays a role. But such studies have not yet been done in our place, and I think will be welcome. So concerning the risk factors, as we have said already, African descent have increased risk of developing fibroid. You have age greater than 35, late first pregnancy, older than 30 years, early menarche, younger than 10 or 12 years, family history of uterine fibroid, nulliparity, obesity. If you go through each of these factors, you say that for the race, many studies have been done in the United States to clearly show that the Black have more fibroids than the white. Then concerning the age, uterine fibroid tend to increase with age through the reproductive years and decline in the postmenopausal years. In Algeria, they have shown that the most affected age in Cameroon, we have shown in one of our studies that the most affected age group varies between 30 to 39 years. In the last study of case control, the most affected group varies between 35 and 40 years. Concerning the age at menarche, many studies have shown that the early the menarche, the increased risk of uterine fibroid. So in Cameroon, we also found that in the case control study that we have done with O ratio of 10.9. Concerning the parity, many studies in Europe and in the other country of Africa, like Algeria, have seen that the nulliparous women have increased risk of developing uterine fibroid than multiparous. This was also found in our studies here in Douala, where we have 44% of women with uterine fibroids who were nulliparous. So uterine fibroids, estrogen. It reduced hepatic production of sex hormone binding globulin, resulting in more abundant active estrogen. In our study, we found that obesity increased the risk of having uterine fibroid by 6.8. Genetics factors have also been incriminated in the development of uterine fibroid, and we also find that in our study. Nutritional factors have not yet been studied in our place, but we have noticed the increased frequency of uterine fibroid in some ethnic groups. Is that genetics factor or nutritional factors? The further study may be done to let us know. We know that ethnic groups here are characterized not only by their genealogy, but also by what they eat. The nutrition is a bit different from one ethnic to another. So this was the table summarizing the multivariate analysis of that study we done on case control. And then after multivariate analysis, we still find that the age, the parity, chastity and parity was a significant factor associated to development of fibroid, the miscarriages. Then the age at menarche, younger than 12 years, the late age at the first pregnancy. And then you have also hypertension was significantly associated, but while going through multivariate analysis, we didn't find it again. During univariate analysis, we thought that it may be because hypertension is also associated to obesity, and then obesity is a risk factor of fibroid. So some factors have been shown to decrease the risk of developing uterine factors. That is the increased parity, multiparosoma, late menarche, smoking, and the use of contraceptive methods. We move through the clinical aspects. Some symptoms, and we have many patients who are totally asymptomatic, and the may be only either during clinical examination or during graphic or reasons. So, or metrorrhagia, increase in abdominal volume or infertility, and during the exploration of the cause of infertility, we find some fibroids. So here are one figure summarizing the clinical aspects of the clinical aspects seen in our patient. You have the most common symptom, which is menorrhagia, 37.4%, followed by metrorrhagia. You see that abdominal mass is an important symptom also. Usually, many women keep their fibroid growing, and they grow bigger and bigger, and it's when they really have some discomfort, when people are telling to them, how are you pregnant and all that, that they will come to the hospital. So the presence of abdominal mass is an important symptoms that we find in our milieu. We also have dysmenorrhea, pains during menses. And then the consequence of menorrhagia, which is anemia. So you have also tried to look out the clinical symptoms according to the position of the fibroid. We use the previous classification of subserous, submucous, or intramural. And then you have seen that menorrhagia is most common in submucous fibroids, and metrorrhagia also. So Cameroonian author Ngoum and collaborators look for the clinical symptoms of clinical aspect of uterine fibroid, and they found that the genital bleeding was found in 63.3% of women, anemia in 95% while doing a foot blood count test, and infertility in 57% of their study population. So they also look for the psychological impact, and the psychological impact was very marked in the population, and that is really true for our milieu. You have women who, because they are bleeding heavily, are very anxious, afraid of the other means of treatment. To the work, that means they cannot go to work heavy, that they cannot leave the house. So those are some impacts that were also found in our milieu. So other symptoms of uterine fibroid, like urinary retention, dysuria, pelvic pain, menstrual cycle disorders, hydrorrhea is some to the submucous fibroid. And then after the bleeding, the woman started having some fluids coming out from her genital, like water, yellow water. So it's very frequent in our milieu too, and constipation. So during clinical examination, you have to look for the medical, surgical, the family past history, ecological and obstetrical findings. You may have women who are anemic with pallor. You may have rarely a low-grade fever in case of necrobiosis. During the examination, usually we have at inspection the enlarged abdomen. At the palpation, you feel the mass, which is regular and firm, polylobed. And then during the speculum examination, we mostly find the deviation of the cervix. And we appreciate also the state of the cervix, because you can have some association with the cervical cancer. Sometimes, while doing the speculum examination, we are going to see a pedunculated submucous myoma, which is delivered by the cervix. So it deviated, and the consistency. The rectal examination is done just to be sure that the mass is benign. There is not infiltration of the parameters, which usually happens when we have cancers. So for paraclinical examination, the most common exam which is used in our milieu for the diagnosis is the ultrasound. Ultrasound, which can be done through vaginal way, transvaginal ultrasound, or transabdominal ultrasound. Transvaginal ultrasound is more specific for the small fibroids. When they are big and very big, we do only the transabdominal one to describe the fibroid. And then we can do the hysterosonography by introducing saline in the uterine cavity to appreciate the figure 0 to 1 or 2 fibroids. Here is just an image of cavity fibroids. Here you have figure 5 fibroids, and you can really appreciate the fibroid inside the uterine cavity. So we also have the hysteroscopy, but not much centers can do hysteroscopy in our place. Hysteroscopy is important to see, to appreciate the fibroid, those who are in the cavity, and do the differentiation with the polyp. And then you can also do the resections when you have materials. So MRI is rarely used, but it's important when you have big fibroids, or when you want to see if the fibroids may have repercussion on the fertility. So you want to really look give much precision, but it is rarely done in our milieu because it's very cost compared to ecography. The price is 20 times the price of the ecography. So for the evolution of the fibroid, usually they will increase in size until the menopause, then they can regress after. During pregnancy, you have also some modification. They may get enlarged, soften, and create necrosis. So you have the necrobiosis, which is most frequent in the pregnancy. Why? It is true that many fibroids are asymptomatic. Complications, however, are possible, and then some complications are just like symptoms also: heavy bleedings, painful mechanical complication, transformation. The transformation to sarcoma is very rare. I've not yet seen it in my practice here, but I've seen one case when I was in Belgium. Obstetrical complications, you can have infertility, which is rare, but we have many women who are infertile who end up developing fibroids. So for the complications, some obstetrical complications seen in our studies: low placental hemorrhage, postpartum hemorrhage, and retained placenta. So here is just a result of one study that we have done that has been published in Journal de Gynécologie, Obstétrique and Biologie de Reproduction. And we see here that the bleeding, the miscarriage, the premature rupture of membrane, the premature delivery were more frequent in people with fibroid than those without fibroids. So also complication according to the baby and the delivery. So were smaller, but then the Apgar score was not much difference. So you can also state as complication, the operative complication. Is true that this part, you may move it upward to the treatment, but you have put it here. So operative complications, immediate complication, you may have wounds of the urethra, you may have bleeding, and then you may have thromboembolic complication. For late complications, usually you have adhesions. Many women who underwent myomectomy in our place will develop adhesions after. And then sometimes when you come again for the second myomectomy, because when they are young and you do a first one, it's more likely that they will come back for another one, because after the fibroid will still the growth on the uterus, and it's sometimes very difficult to do the second myomectomy because of adhesions. So for the clinical forms, we can have forms associated with infertility. Usually the fibroids class 0, 1, or 2 of the FIGO classification may be associated with infertility. Concerning differential diagnosis of fibroid, usually when you are facing with genital bleeding, you have to rule out in our place the cervical cancer, which is more common, very common also, the endometrial cancer. When we are dealing with pelvic mass, it may be pregnancy or ovarian mass. When we are dealing with pains, it may be endometriosis or ectopic pregnancy, or other compressive tumor or annexal torsion. So, concerning the management, the aim of the treatment is to improve the comfort of the patient, to remove the tumor if necessary, and then bring some support when you have complications. For the means, you have abstention, don't do anything, medical or surgical treatment. The treatment should be based on the symptoms, the patient age, the necessity of preserving the fertility or no, the availability of the therapy you want to apply. So concerning the abstention, usually when you have asymptomatic fibroids, you don't do anything. If you have asymptomatic fibroids in a woman with infertility, and then the fibroid is less than 5 centimeters, we also don't do anything. If we have asymptomatic fibroid of less than 10 centimeters in woman who does not wish more children, we also try to wait if she can reach the menopause before, hoping that at the menopause, the fibroid will reduce as we know. So the means that are used in our place you have the medical therapies to reduce the volume or reduce the menstrual blood loss. So medical management involves essentially hormonal therapies and anti-hemorrhagic drugs. So for hormonal therapies, you have the progesterone. Usually progesterone are used when you have heavy bleeding to reduce the bleeding. You have also analog of the GnRH, the gonadotropin releasing hormones that may be used, but you rarely use it in our milieu because they are too expensive. They are very cost effective, so usually it's difficult for a patient to pay for them before paying for the operation, so they are not very much used. These are examples that are available in our place. So we also have antifibrinolytic agents that you use, anti-anemic ions, and then you may transfuse when the anemic is severe. You may have anti-inflammatory drugs to reduce pains when you have necrobiosis. So in one study done in our hospital, we have seen that the progesterone were used in 30.5% of women, and then the surgical treatment, no treatment, 60%. That means in this population, there were many asymptomatic women. And then concerning the operative therapy, we have the myomectomy and hysterectomy. So according to the position of the fibroid, we try to look which type of treatment were used. So when you have the submucous fibroids, the progesterone therapy is more often used because they bleed a lot, and you also have more surgery. So for the surgical means, you have the hysterectomy. You know that uterine fibroids account for more indication of the whole hysterectomy in our place, 58.2% in a study published by Egbe and collaborator. And you see sometimes you have very, very huge fibroids here, like here. Then, so for the symptomatic, 64.15%, which are the indication of hysterectomy. This was that study, another study published by Nana and collaborator in our hospital. So for the myomectomy, we can do the twisting. This is a removal when you have a fibroid delivered through the cervix. We can have the hysteroscopy resection. This is not so frequent in our place, but just because we don't have many hospitals don't have the equipment, and then usually many women have more fibroids. It's rare to see a woman just only maybe with one submucous fibroid, or that we can go and do the resection. Laparoscopic myomectomy can be done too, but it's very rare because their indications are not much common. But one of our colleagues tried to publish a paper in few cases of laparoscopic myomectomy that were done during some period. But the indications are not really more common. So usually the myomectomy is done through laparotomy. So laparotomy is indicated when you have voluminous and numerous fibroids. Usually in the case of recurrences, because you have a lot of adhesion, when you have contraindication of hysteroscopy and laparoscopy. And as I say, it is the main conservative treatment done in our milieu. So this is the myomectomy. We have to remove up to 92 fibroids in our experience. And then you reduce the intraoperative with the uterine catheter. You go and occlude the uterine artery, then to reduce the blood loss during the myomectomy. We also use the tranexamic acid perioperative, and sometimes before the operation, we use the misoprostol. Okay, so uterine fibroids are benign tumors with multiple clinical manifestations. They do not require treatment if they are asymptomatic. In the case of the existence of clinical manifestation, treatment must take into account the age and the desire for pregnancy. Management requires a good selection of indications and an informed choice by the patient. Thank you.
Thank you, Dr. Tichet. Now joining us is Dr. Muyigo Mark Tumusanke, who is Managing Director and Fertility Specialist at the Neogenesis Fertility Center in Uganda. He is also laparoscopic gynecological surgeon at Mulango Women's Specialized Hospital and at the Doctors Hospital, Seguk in Seguk.
Hello, I'm called Dr. Muyingo Mark. I'm an obstetrician and gynecologist from Uganda. And I work with Neogenesis Fertility Center, as well as Makerere University College of Health Sciences as a lecturer in the Department of Obstetrics and Gynecology. Now I'm here to talk about uterine fibroids, basically as we see them in Uganda, and basically talk about a number of issues, the statistics that we have, treatment options available, advocacy and awareness that has been created, as well as issues on policy, research, and well, the way forward. Basically in Uganda, we have a paucity of data in Africa, especially, particularly in sub-Saharan Africa, about uterine fibroids. We have a few published studies which report the prevalence of uterine fibroids. Because the issue there majorly is because the fibroids may be asymptomatic most times in about 50% of the cases. And when they are diagnosed, sometimes it's an incidental finding when someone comes to hospital for some other complaints. But in Uganda, there was a small study which was done from Kampala International University. It's a teaching hospital in Western Uganda. And it found that the diagnosis accounted for about 1.7% of admissions to the gynecology ward. And out of those 50%, 57% of the patients were within the age of 40 to 49. And the low admissions could be due to fear of surgery by most patients opting for other remedies like herbal medications. And of course, the condition progresses until finally they have to come to hospital. So we don't have a lot of information, but there's quite a lot especially in the tertiary institutions, a lot of the gynecological cases that come in have a relation to fibroids. We have a number of treatment options which are available in Uganda. We have medical management, we have surgical management of different levels. For the medical management, of course, we use the symptomatic relief. We've used the tranexamic acid, non-steroidal anti-inflammatory drugs. We've used the gonadotrophin releasing hormone analogs. One of the commonest ones here is loperamide and Zoladex, which are given to some of these patients. We also have surgery. Surgery can be, of course, a total abdominal hysterectomy for those fibroids. For women not having any desire to have children, or for those very, very big fibroids, that might make it impossible to achieve hemostasis when you definitely have the surgery. But of course, we also do myomectomy. The myomectomy can be open and can also be laparoscopic. Even the total abdominal hysterectomy can also be open or laparoscopic. So we have both keyhole surgery as well as open surgeries for that. Of recent, we have had interventional radiology that has come onto the market in one of the hospitals in Kampala, where they do interventional radiology. We are still a little bit concerned about those women who might desire to have, who are desiring to conceive, but have been reliably informed that the interventional radiology they do is not only uterine artery embolization, but embolization of the vessels going to the fibroid itself. So, and of course, the other remedies majorly circle around symptomatic relief. Now, about education, advocacy, and as well as awareness, we have a lot of stigma surrounding uterine fibroids in Uganda. We have a number of reports which have been published in the local newspapers about women presenting late because they fear to reveal the diagnosis because it is associated with the divorce, and scorn from relatives when they have such diagnosis. One of the media groups, major media group, which is called the National Media Group, launched an awareness program, a drive and education through its sister companies. And in March last year, they ran a series of articles and interviews with patients or survivors, as well as health personnel on uterine fibroids. And they partnered with a number of hospitals in the country to offer free gynecological screening, as well as discounts on investigations for uterine fibroids. And of course, during the COVID lockdown, many of the civil society organizations resorted to Zoom interactions with the general public. And so public could attend these Zoom sessions, as well as the popular topic of discussion was majorly uterine fibroids. And so majorly to increase public awareness on the symptoms and relief. We don't have any policy about uterine fibroids in the country as such, but we have the National Reproductive Health Policy and Sexual and Reproductive Health, and other guidelines that we have, for example, guidelines on management by the Ministry of Health, standards of diagnostic, imaging and therapeutic radiology for Uganda. They talk about fibroids, the Sexual and Reproductive Health Policy. They also talk about fibroids. So there are quite a number of them, but there is no one particularly on uterine fibroids. On issues of research in our population, I think we need to do a little bit more to study and expound on the body of knowledge of other things, for example, like vitamin D3 supplementation as a cost-effective management of uterine fibroids, both management and prevention. We've had it in a number of areas, we've seen it. as well as evaluation and endocrinological disrupting chemicals that are available in the population. A lot of our people use cosmetics as well as pesticides and other things that have been found in some studies I've seen, like from Nigeria, which show that there's an increase in fibroids in people who use those. So we need to have a number of studies to inform about prevention, about prevalence, incidence of fibroids in the society. And that could help inform policy as well as standards in the country, especially for some of the cosmetics that come into the country. And of course, for me as a reproductive health specialist, especially dealing with infertility, I would say that I see a lot of fibroids, and most of the surgeries that I have to do circle around uterine fibroids. So we need to definitely do a little bit more, and of course need support from partners, support from some of our neighboring countries about what we can do on uterine fibroids, because it's an area which is poorly studied, and not like maternal health, especially in obstetric cases. So I think we need to do a little bit more in that area. Thank you for listening to me, and maybe at this point I could ask for some questions about that.
Next, we will hear from Dr. Godfrey Chale, obstetrician gynecologist in Dar es Salaam, Tanzania. Dr. Chale is a specialist gynecologist oncology and provides laparoscopic intervention for his patients when possible.
Total abdominal hysterectomy in Dar es Salaam regional referral hospitals in Tanzania. This is my outlines. First, background, then I will go to the goal, methods, results, discussion, and conclusions. In background, hysterectomy or malignant indication. The hysterectomy is divided into two groups, which is the abdominal hysterectomy and the subtotal abdominal hysterectomy. We have total abdominal hysterectomy and the subtotal abdominal hysterectomy. Hysterectomy is variable in different parts of the world. Factors responsible for hysterectomy has variations. First is the patient-related factors and the physician-related factors. Procedure in Tanzania remains unknown. No published evidence of conduct or burden effect and the other associated factors for total abdominal hysterectomy in the city of Dar es Salaam, despite any data proof as a equivalent gynecological surgery. Moreover, clinical indications that resistate surgical interventions of total abdominal hysterectomy in Dar es Salaam hospitals is not early unknown. Rationale admitted in the gynecological units or regional referral hospitals. Empirically derived knowledge, especially given paucity in information Dar es Salaam. Why Dar es Salaam? Remember, Dar es Salaam was the 9th fastest growing city on earth and the 31st fastest in the entire Africa in 2020. Objective of the study. The objective was to determine clinical indications for abdominal hysterectomy at the regional referral hospitals of Dar es Salaam among women at regional referral hospitals who attended who has hysterectomized at the regional referral hospitals in Dar es Salaam. Also to determine the prognostic factors that are associated with early complications among women who underwent total abdominal hysterectomy at the regional referral hospitals in Dar es Salaam, Tanzania. Methods. The design was prospective. Setting was Dar es Salaam regional referral hospitals, which were Amana, Mwananyamala, and Temeke. Time frame, it was from March to October 2017. And the study population, there are those patients admitted for abdominal hysterectomy in the Dar es Salaam regional referral hospitals. And the target population was planned to underwent abdominal hysterectomy in Dar es Salaam regional referral hospitals. Follow-up. Start time of admissions, starting time was the time of admissions for surgery at the ward, and the end time was 72 hours post-surgery, or discharge time from the ward. So the end time of the after discharge, so all the follow-up was ended there. Initial data exploration, continuous data, and your categorical data. Continuous data summarized using the median IQR, and the categorical data summarized using the frequency. Main analysis was multiple logistic regression. Results. The study managed to recruit 107 women with 30,060, 81 women per days of follow-up. Also, I will explore the table of results through the PowerPoint presentations. You can see them. We have 3 tables, each 100 women with 30,060, 181 women days of follow-up. In the second table, that is the, and the table 3, which shows the frequency distribution of participants by type of surgical hysterectomy at Dar es Salaam Regional Referral Hospitals from March to October 2017. And the variables factors were surgical procedures, which was names total abdominal hysterectomy, and the total abdominal hysterectomy, which was also done with the bilateral subpingual oophorectomy. And also we have those total abdominal hysterectomy with the exanterations, and also we have total abdominal hysterectomy with the cystectomy. Also, you can see the table through the table for results, which you can see through the PowerPoint presentation. Also, we have table 4, distribution of indications for hysterectomies done at the Dar es Salaam Regional Referral Hospitals from March to October. Also, in this table, it shows that reportedly surgical indications who have been, the surgery was made, the reason was uterine myoma. It was about the frequency, it was 90, which is the highest. So the main cause of hysterectomy was the uterine myoma. And also another reason for surgery, it was chronic pelvic pains, frequency was 60. And also abdominal uterine bleeding with the 3 frequencies, ovarian tumor 2, and also AL malignancy CIN 3, it was 2, endometrial carcinoma 1, endometriosis 1, and the uterine myoma with the ovarian cyst 1, and the uterine prolapse also was 1. So that's the table 4. Now table 5 also shows the frequency distribution of early post-operative complications among women who underwent abdominal hysterectomies at Dar es Salaam Regional Hospitals at that time. Also, we have post-operative variables was the frequency reported. We have variables, then the frequency reported in proportion by percentage. So the variables was post-operative persistent pain, and you also have post-operative headache and the post-operative fever. Those have been shown in table 5. Also, we have table 6, which show the prognostic factors of early complications following abdominal hysterectomy at the regional referral hospitals at that time. And here we have factors, and also we have odd ratios, confidence intervals. So the factors were HIV status at this, also anemia. So it's the confidence interval for 95. We can see that HIV status were 2.8, and also anemia it is 1.9. with the percentage intervals of HIV were 7.49 and those for results of table 5. Also, results of that is of table 6. Now we have results of table 7, which shows the age and the HIV status. At this table 7, we have distribution of HIV status by marital status among women, those who underwent the total abdominal hysterectomy, and we have those who are HIV serostatus, we have seropositive and seronegative. Also, they are shown in the table 7. Now, discussion. Interesting findings from the current follow-up. Age associated with HIV risk. Among almost half, 45% of our study were nulliparous with at least the para 3, and the others are similar in similar areas. Uterine leiomyomata was about 85%, for the leading indications for total abdominal hysterectomy in Dar es Salaam, and visually all 98.1% women reported persistent pain postoperative. So most of the patients were operated complaining of pains, about 95% postoperative pains. So it shows that we will also need more interventions to manage those postoperative pains, because the patients were complaining of severe pains postoperative, although they had been given analgesia, but those analgesics which had been given were not very strong or not powerful to decrease the pains. Now, conclusions. Uterine leiomyoma was the leading indication for total abdominal hysterectomy in Dar es Salaam hospitals. Nulliparous women formed the biggest group of hysterectomized women in Dar es Salaam hospitals. Age was associated with the HIV risk in this study population. Virtually all women reported postoperative pain. Recommendations: more analytical studies are warranted in view of the higher rates of nulliparous women undergoing total abdominal hysterectomy in Dar es Salaam hospitals. Clinical audit is highly recommended to all gynecologic surgeries in Dar es Salaam hospitals. The burden of polycystic ovarian syndrome and its associated clinical aspects are likely to be causal. Thank you for your attention.
Next, we will hear from Dr. Daniel Yebo, who is general practitioner with a surgical inclination in obstetrics and gynecology, including pediatric surgery. He is currently one of the surgeons at the Hawa Memorial Xavier Hospital in Ghana.
All right, thank you. I give God thanks for favoring me this far. Greetings to everyone, and special greetings to Professor Al-Hindi and Lillian, my faithful friend, and then Mrs. Elizabeth Kurasari, the director of Fibroid Foundation Africa. My name is Dr. Daniel Kofi Abua, a medical practitioner at the Hawa Memorial Xavier Hospital, or CM in Ghana. A medical officer or a medical practitioner, yet I am a lot into surgeries. My presentation is as seen on the screen. Uterine fibroids, the story so far. Presentation outline is as seen: brief introduction, statistics on uterine fibroids, treatment options, mostly in my hospital, education, policy, and research. Brief background. Uterine leiomyomas are one of the most common and yet understudied diseases in women. These tumors, commonly known as fibroids, affect women mainly during their reproductive years and are diagnosed in up to 70% of wives and more than 80% of women of African ancestry during their lifetime. Now, this disease has a profound impact on health care delivery and cost worldwide. Though most women with fibroids are asymptomatic, many present with issues which may include infertility, dysmenorrhea, menorrhagia, leading to anemia and its associated problems, stigma of being tagged as pregnant or seen as obviously sick, feeling of growing pelvic mass that is disturbing to the patient, pelvic pressure, and obstructive uropathy secondary to uterine fibroids, many of which cases I've handled in my hospital. Pregnancy coexisting with fibroids, the recurrent miscarriages, and most often than not, fear of death. A study conducted among Ghanaian women undergoing pelvic scans with suspected uterine fibroids revealed 23% of women less than 35 years had fibroids, and 67% of women 35 to 44 years also had fibroids, and 73% of women at 45 years and above also had fibroids. The study indicated that the highest prevalence of the fibroid cases was found among older women in the reproductive age group. The trend of fibroid prevalence in this study is consistent with findings of Louis et al., which estimated a prevalence of uterine fibroid as 4% in women aged 20 to 30 years, 11 to 18% in women between 30 to 40 years, and 33% in women between 40 to 60 years. The prevalence of fibroids, now limiting myself to what happens in my hospital, the Hawa story. The prevalence of fibroids has been underestimated, the main focus being on symptomatic women, leaving behind a large population of asymptomatic women and women who underreport their symptoms. This is consistent with history of epidemiologic studies on fibroids. My hospital sees an average of 2,050 new patients monthly. About 59% of these patients happen to be females in their reproductive age. Over the last 5 years, between 5 to 16% of the newly registered females in their reproductive age report to the hospital with fibroid-related conditions. Preliminary analysis of the facility's data shows fibroid is more prevalent in women between the ages of 35 to 49 years and 20 to 34 years. There are some few reported cases among women 50 years and above. Now, treatment options available in my hospital. Surgical procedures are the treatment options currently used in my hospital. A patient with a desire to have a child or continue to have more children. A patient here refers to those that have been diagnosed with uterine fibroids. So those that, patient that have children and desire to have more children are counseled for myomectomy. And those with no desire to have any child or any more children are counseled for hysterectomy. Currently, education, advocacy, and policy, the giant leading education, advocacy, and sensitization on uterine fibroid in Africa is the Fibroid Foundation Africa. We recommend funding support to establish more focus groups in health facilities and communities to educate more people about the underreported cases of uterine fibroids. Some believe uterine fibroids are of spiritual origin. As a matter of fact, they resort to other means of managing such cases, going to shrines and other things. And this delays treatment a lot. Falsely, others are made to believe they are pregnant a kind of pregnancy only seen by the prophets or spiritual leaders and not a medical doctor. These people tend to seek spiritual help, which eventually delays seeking medical intervention. In this regard, education is the way out, because many of them do not know and are not aware of whatever is developing inside them. So they tend to believe any stories around it. And as they are started with stories like this is of spiritual origin, can give you this concoction to melt it away, and many, many others, they fail to listen to doctors, they fail to report. And so their condition delays and their problems worsen. Funding and policy support for diagnostic infrastructure for health facilities to detect the asymptomatic cases of uterine fibroids early enough among all women in their reproductive age who report to the various health facilities is recommended. Additional funding support and training to explore treatment options for uterine fibroids, minimally invasive surgical procedures and non-surgical treatments is also highly recommended. Any research that can address the development of fibroid in women is greatly welcome. More research needed to explore treatment options, including pharmacological treatments of uterine fibroids. A push for an act similar to the Stephanie Taft-Jones Uterine Fibroid Research and Education Act 2020, currently being considered in the US Congress to expand national research efforts and bring much needed attention to this overlooked disease, will be a step in the right direction. Yes, fibroid is an issue, but not one that the human ability cannot overcome. And so our women, just speak to a doctor and your concerns will be addressed appropriately. Many have had fears of death, fears of going through difficult surgeries. And eventually, when they are able to tell themselves, come what may, and they report, they end up being well. And we give God thanks. So I would say there is a way out. Women, don't hide in your corners and suffer. Just speak to a doctor and your concerns will be addressed. I have these references. Thank you very much.
We'll hear from Dr. Olutosin Awolude, a senior lecturer in the Department of Obstetrics and Gynecology, College of Medicine, University of Ibadan, Nigeria, and an honorary obstetrician gynecologist of University College Hospital in Ibadan, Nigeria. Having more than 23 years of experience, his research interests include ensuring evidence-based, cost-effective, sustainable reproductive health programs with special interest in preventive gynecology oncology, abortion-related complications, prevention and management, and HIV and AIDS in obstetrics and gynecology.
So good day, everybody. I will just be giving a brief talk just to share my thought about fibroids in Nigeria. It's not an academic talk per se. I think it's more of a thought-provoking talk and just to see a little about fibroid situation in Nigeria. So I've subtitled this, the number, which will be talking about the prevalence, is a perception based on some work done in Nigeria, the myths and the misconceptions surrounding fibroid, which I will just show a slide talking about that and listing some of those myths and misconceptions. Well, as a form of introduction, uterine fibroids, benign tumor, which is very known to all of us. And usually it's fibroids with high collagen content as one of the common pathologic abnormalities of the female genital tract. In fact, it's the commonest neoplasia of the uterus. That's the commonest tumor of the uterus that we see in this environment. Because, I mean, maybe it has some biological implications of our situation because we see a lot of fibroids. When I was in medical school, maybe fibroid would be said not to be seen in people less than 30 years now. But in my little years of experience, I've had to operate huge fibroid among 24, 22-year-old females. So that is another dimension to fibroid in Nigeria. They said to occur about 3 to 9 times more frequently in Blacks than white women. And between 20 and 50% of women greater than 30 years, we actually harbor fibroid in one way or the other. And this has been confirmed from findings from autopsies. And by 5th decade of life, up to 50% Black women will have fibroid. Like I said, it is the commonest indicator for gynecological surgery in Nigeria. And when we talk about abdominal mammectomy and abdominal hysterectomy, which are the common form of treatment in Nigeria, and people have estimated that the annual cost of managing this benign condition runs to billions of dollars in most sub-Saharan Africa, including Nigeria. Well, I've tried to cite the literature of work done in Nigeria, and I've put some prevalence for those that are familiar with the map of Nigeria. We have 6 geopolitical zones and cutting across the northern part of Nigeria, the southern part of Nigeria. And from the northern part of Nigeria, this is from Kaduna State, the teaching hospital. And among their gynecological admissions, 7.8% of them are due to uterine fibroid, one way or the other. And coming down to the southern part of Nigeria, looking at the central part of Nigeria, this is Kwara State, Ilorin precisely. In their own audit, it's about 13.4% of all their gynecological admissions. In Oyo State, where I have practiced, the work done there has shown that 9.3% of all gynecological admissions are due to uterine fibroids. And this is similar to what is found in the eastern part of Nigeria, which is about 9.8%. So you can say that, yes, it forms about 1/10 of all our gynecological admissions in Nigeria. And this is almost similar throughout the country. By the way, Nigeria has a population of about 200 million by estimate as of today. So what are the usual presentations? I've used this picture to say that fibroid findings in Nigeria are usually huge. You can say this huge, this from one of my surgical procedure. This is a huge, fibroid, solitary fibroid. And at times can be multiple. And you can see from your right answer, you can say this is from a patient I operated on some years back. This fibroid nodules from just one patient. So usually we see fibroid in our setting in a very, huge situation. You can have fibroid as big, fibroid uterus as big as 36 weeks in our setting. And talking about patient knowledge and particularly about uterine fibroids in Nigeria, we realized that in this work by Adegbeson and et al., they realized that out of about 400 participants that they interviewed, 97% of the respondents believe fibroid is only seen in fertile women. So that is their perception. And of this 400 and something plus, 270 of them believe it's a spiritual problem. That is one of the myths and one of the things we have to cope with in our setting, in the sense that a lot of them see fibroid as a spiritual problem and rather than seeking for medical intervention, they will rather go to traditional people to seek for help. And, a lot of them have got into wrong hand, and they give them all sorts from herbal preparation to drink, to inserting some things into the vagina, giving some other medical complications, including narrowing of the birth canal, and some outright obliteration or occlusion of the birth canal in form of gynecomastia. And about 1/50 of them believe fibroid affects childbearing. And these are some of the perceptions from this work by Adegbe Sonilabu and co in Lagos. Where just about treatment of fibroid in our environment, because we see a lot of them with very huge fibroid, expectant management is not as common. Or however, when we see small fibroid in some incidental firefighting, especially for those that have been evaluated for infertility, expectant management might be used. And but also the other downside of this kind of incidental findings is that in some settings in our country, a lot of people make money from it. Fibroid you should manage expectantly. Some of them physician can offer to even remove such fibroids. And this can affect the woman because there's no procedure without its own side effects. But in terms of real management, surgical extirpation is one of the commonest methods of management in our environment. And by this, we do mammectomy, which is a conservative surgical method. And in our setting, abdominal mammectomy, that is open abdominal mammectomy, is commonly used. And there are few centers that can perform laparoscopic or stereoscopic mammectomy. And usually these are in private facilities, and a lot of time, this is usually very expensive and beyond the reach of average Nigerian. The other common surgical intervention for fibroid that is done in our environment is hysterectomy, that is removing the womb. And again, abdominal hysterectomy, that is open form, is the commonly used method. And also vaginal hysterectomy, especially for some troublesome submucous fibroids in some older people that have completed their family, can also commonly be practiced. But laparoscopic hysterectomy, also not widely available in public facilities in Nigeria. You see a lot of this being done in private facilities and usually very expensive. So also the stereoscopic method of assisting removal of this uterus at times. Well, endometrial ablation or resection also being done for some form of submucous fibroid, also commonly performed in private facilities. However, uterine embolization is an upcoming procedure to manage fibroid in our environment. There are a few intervention radiologists work with gynecologists now that have been performing this. A lot of them also will be found in private setting, and a few public settings also engage in that. And then, but usually it's seasonal. It's not something that we routinely do in most of our public settings here in Nigeria. Other options that are available, especially when mammectomy or hysterectomy is ideal, myelitis. This is not common in Nigeria, and even globally now, this is something that people are actually running away from because of some other associated problems with it. However, medical management like the use of GnRH analogs, danazol, are also commonly practiced in Nigeria, especially for those that are either too weak or not in good shape for surgical intervention, for them to actually recover, or some people with very huge fibroid that will require making very large abdominal incision, and you want to reduce the size of the fibroid outlet. Mifepristone, antiprogesterone, raloxifene, fibroxone, those are not commonly available in our setting, so we don't commonly use this medical method of management. The other thing that is commonly available in our is the levonorgestrel intrauterine system, especially for some small submucous fibroid, and especially in women that are very close to menopause. You can just use this and then put it in the uterine cavity. That will shrink the endometrium, and then that will ameliorate the problem associated with fibroid, usually in this case, bleeding, abdominal bleeding from such women. And we have, this also readily available in our setting. In terms of where our patients get information about fibroid, and we see that, or in terms of where a lot of them are being educated, this is from an evaluation by another group. We realize that radio is a common source of information for a lot of our patients based on what they actually responded to. Then parents and relatives comes next to that, whereas healthcare workers also are good source of information for our patients, but then a lot of them get information from outside the health sector in most cases. Then you ask me that, okay, how about this radio information? Who are the people providing such information? Various type of people, where healthcare workers might be included in that, but you see a lot of other people talking about this fibroid in radio, especially those that are doing for commercial purposes. And you can be sure these are people that are traditional medical practitioners and all those things. Then television is also another method, avenue on where our patients get information about uterine fibroid and the management options. But by and large, the other thing is that the use of radio and television is more utilized by the traditional healthcare workers than even the orthodox healthcare workers. Now to the common myths about fibroids in our setting. I'm just going to list this and then I will just talk around some of them for the sake of time. That hysterectomy, one myth is that people say hysterectomy is the only fibroid treatment options. Well, this is a commonly said, made statement, and this is usually done by people that have only limited skill to removal of the uterus, and this will be found in a lot of non-public health sectors because they want to maximize their customer out of that. The other myth is that fibroids are meant to be removed on priority, right? Meaning that when you see fibroid, it must come out. This is another common myth that people, peddle around, and this make a lot of people to be so scared about that. Like I said, a lot of fibroid need not to be removed. And some people can still even carry their fibroid up. So there are clear indications for removal of fibroid. Then the other one is sexual function within the body is hampered after fibroid treatment. In fact, that's one of the reasons why a lot of our patients run away from surgical management of uterine fibroid environment. They believe that once they have surgery, then something is going to happen to their body and all those stuff. Then the other thing is fibroid treatment will stop you from being pregnant ever again. Well, this is a common statement. In fact, one of my patients told me that when I was trying to find out from her why she has delayed in presenting for management, said that, since she was still planning to get pregnant, she was advised not to get the fibroid removed. Otherwise, she might not be able to get pregnant again. But interestingly, after convincingly removing the fibroid, just about 7 to 8 months down the line, she became pregnant. And that was, what I just simply told her was that, please, now you are an advocate, go out there because you come across of other people with similar information and let them know that that is not absolutely true. The other thing is that seek fibroid treatment only when you observe symptoms. Well, a lot of people, the symptoms, it can be very subjective to a lot of people. I've seen people with very huge fibroid. The only thing when I find out that, oh, they have fibroid and this is huge, the only thing is that they never knew they have fibroid, that they thought they were just getting fat, and because of that, so they never bother about it. So this is another commonly stated myth. The other one is fibroid surgery always results in death. Well, this is also a scary myth, and we cannot blame people because we've seen some cases that people have fibroid removed. In fact, very known people, celebrity in our environment, that had surgery for fibroid and in the process maybe died, and this usually spread very fast. And that's one of the things that people now, hinge their inability or failure to seek medical intervention for fibroid treatment. And at times it can be difficult to change people's mind from this. The other one is that fibroid equals cancer. Although we know that cancer resulting from fibroid can occur, but the percentage of such cases is usually very, very low. So people equate fibroid to cancer, and some patients, when you tell them they have fibroid, well, they find it difficult to treat them for cancer, and you need to spend quite a lot of time with them to actually remove that from their, from their thinking. Then the other one is that when you have fibroid, you will know. Well, that makes some people to come when the fibroid is so huge. However, there are some people with fibroid that is small, depending on the location, that can have massive bleeding from such tiny fibroid. And some people delayed until they now get to a stage of being transfused or they collapse, and then only for them to report that, oh, this is a result of fibroid. And they say, oh, but I was told that if I have fibroid, I will know. Well, we never knew that this is a sign of fibroid, all those things. Then the last one I talk about that is that when you have fibroid, surgery is the only option. Like we said, surgery might not be the only option. There are some cases that, because they are very close to menopause, we just encourage them. And depending on the symptom they are presenting with, we can just manage conservatively or expectantly until they get to menopause and the fibroid will shrink. So I think by and large, that is about the myths and misconception. Policy on fibroid in Nigeria, fibroid, though of medical importance, public importance to inform policy, not well championed. And a lot, unlike some other medical conditions that have clear-cut policy statements, policies about fibroid and what to do are still, the statement about fibroid and what to do are still within the medical institution and medical practitioners. And so I believe that it is high time that people that have been through the issue of fibroid and should be part of the advocates for us to develop a kind of policy statement on the management of fibroid. Research on fibroid, very few, except for documenting the prevalence and then all those things. But now, even those little ones are usually at individual levels, and people just out of pocket spending to just document, audit their system and all those things. But however, there are a lot of areas that people can focus on. Like now I have a family that the grandmother had fibroid, the mother had fibroid, and then there are a set of twins, the two of them have fibroid. It was one of these twins that came to me for infertility evaluation, and then we find fibroid, which we removed, and then she had a baby. And then after that, this twin sister came and then also had mammectomy, but still yet to get pregnant. It was in the process that we found out that the mother also had fibroid surgery some years back. And it was the mother that told us about the grandmother, their grandmother having fibroid. So some people are believing to, looking at documenting familiar tendency to uterine fibroid. And This is also closely related to some documentation about the genetics of uterine fibroids, so people are looking into that. These are some of my thoughts about areas that at least people can spend some time on to actually document and then form a research base. I think by and large, that is my VA talk, and I thank you for your time listening to my talk. Thank you very much.
Next, we will hear from Dr. John Jude Kweku Annan, who has keenly applied himself to the pursuit of excellency in medical practice throughout the medical career in Ghana and the United Kingdom, practicing as a consultant obstetrician and gynecologist and reproductive medicine, infertility, and assisted conception subspecialist and teaching medical and postgraduate students from various social and cultural backgrounds. Dr. Annan will speak about the myths of fibroids.
Thank you very much, and good morning to us all. And I hope my screen is visible now.
Yes, yes.
Thank you. We can proceed. So my name is John Jude Kweku Annan. I work in Ghana as a senior lecturer in Kwame Nkrumah University of Science and Technology, and also a consultant of obstetrician gynecologist and infertility specialist in the same institution. I want to thank Fibroid Foundation Africa for this opportunity for us to sit down and brainstorm and see how far we can help all these women who are afflicted by this condition. It seems all the previous presenters have done most of the things that I'm going to talk about, so that makes my work very easy. First of all, I have no conflict of interest to declare, and I'll proceed to say that the scope of my presentation will move from an introduction. We'll look at some of the myths associated with uterine fibroids in our sub-region. I think a great work has been done by the previous presenter. We'll look at myths associated with the causes, the clinical presentations, and then the treatment. And not only look at the myths, but we'll see how we can demystify all these issues related to fibroids. So these are the cases that we are looking at, these huge multinodular structures that we see coming from the uteruses of most of these women that we see in our practice as obstetricians and gynecologists. I will not belabor the point that we have a huge fibroid burden in sub-Saharan Africa. That has been confirmed by almost all the presenters since yesterday and today. We also know that these fibroids have varied and significant presentation. Some may present with menstrual irregularity, mainly excessive menstrual bleeding. Some may present with pressure symptoms on the bladder, on the bowel. Some will have painful presentation, such as pelvic pain, back pain, and some may actually lead to painful sexual intercourse. Of course, subfertility and infertility is also another huge burden that fibroids pose. Some types, even when the woman becomes pregnant, may predispose her to recurrent miscarriages. So it's of a major public health issue. It causes significant morbidity and mortality in our women. And of course, when it comes to quality of life issues as well, it has significant effect on these women. Now, briefly, I'll show some few cases that I operated on recently. So case one, these are the fibroid nodules that are removed from a 37-year-old woman who was trying to conceive for 10 years. In fact, a doctor diagnosed her of uterine fibroids 5 years previously, but she declined surgery and she resorted to herbal preparation that she claimed the practitioner said were going to shrink all these fibroids. Well, obviously, the herbal medication failed and she came to us and we had to do a myomectomy. And we took all these nodules from one single patient just January this year. There's another case where also the case of infertility, huge fibroids removed. She was told that she has been bewitched by the relative who doesn't want her to become pregnant. So stones have been placed in her womb. And so she stayed at a prayer camp for years until finally she realized that no, she saw the light. I have to get these nodules out. We did a myomectomy. Thank God she conceived after IVF treatment. So you can realize that most of these patients are staying away because of all these myths that they've been told about their fibroids. For this one, she has significant anemia, yes, had blood transfusions, also resorted to herbal medication that they said were going to help her stop having the heavy menstrual loss. And finally, we did a myomectomy, and these were the nodules. This one was told that she had cancer. That's what she thought. And we removed this huge nodule from a patient. She's waiting for IVF. In this case, I intentionally showed this because she's a 26-year-old. There's that myth that fibroids, we don't see it in very young women. But 26-year-old, and remove this fibroid nodule from her, and then she's doing well as well. And of course, this one, we did it for infertility recently. You can obviously see her ovary, the fallopian tube is there, there are fibroid nodules there, and a huge nodule up there. So this can compress the part of the tube that enters into the uterus, and may be the reason why she wasn't becoming pregnant. Why am I showing all this? So most of these cases that I've presented show that these patients came in very late. And why did they come in very late? I'm sure it's because of all these myths that they've been told about fibroids. Of course, we know that the cause of uterine fibroids is unclear. And once the causality is unclear, of course, it's prone to myths, spiritual causes, curses, and other things. Additionally, we Orthodox practitioners hardly get access to these women and talk to them. Because if you look at the previous presenter from Nigeria, his findings are clear-cut. These women listen a lot to radio, televisions, and this is the medium that most of these traditional herbal practitioners use to reach these women. Of course, effective treatment is limited by these myths because they believe in them. In fact, there's a myth in Ghana in which some of the women believe that if I'm menstruate and the blood flow is not significant, it's not enough, it means that a lot of blood is staying inside me. That blood, as the months go by, taken up, becomes solidified, and then that is what turns out to be fibroid. So all these myths, we have to make sure that in our practice, as we reach out to these women, in our advocacy programs, we try and make sure we demystify these myths in the women. The second myth I want to talk about is myths concerning the symptoms of fibroids. I remember when I was in medical school, the teaching that was started was that the commonest way fibroids present is that they are asymptomatic. But from the discussion that we've had from yesterday throughout this day, realize that some fibroids do cause symptoms, and these symptoms are very, very significant. Of course, the finding that fibroids do not seem to arouse cause symptoms will not lead to keen interest and concern that it should. Even if a young woman comes to complain that, oh, my menses these days, I have a bit of pain during menstruation, usually we say, oh, that's normal woman's problem. Why are you alone complaining about it? So we shouldn't discount these things. We should have time for these women, investigate and see. Probably they may have fibroids, and in early stages, we can be able to put in measures to prevent these fibroids from getting bigger and causing all these problems that may arise to the woman, such as pelvic pain, frequency of menstruation, heavy bleeding, reproductive dysfunction, and of course, depression, which we hardly look at when we see these women in our clinics. The third myth is that we claim that younger people are unlikely to have fibroids. And other presenters have shown that fibroids has no respecter of age. Once you're in the reproductive age group, there's that tendency that you can have fibroids. And so we need to look out for these uterine fibroids in younger women who present to the gynecologist or to all our doctors, conscientize them and see how we can be able to counsel them and manage these accordingly. The fourth myth is that fibroids and infertility and pregnancy. Once I have fibroids, I cannot get pregnant or keep a pregnancy. We know that some uterine fibroids are responsible for subfertility. We know that. And those that are pushing inside the lining of the womb, the submucosal ones, could be a reason why a patient may have recurrent pregnancy losses. But the good news is that many women with fibroids can conceive spontaneously without them knowing. Sometimes during routine antenatal scanning that we see that, oh, you have fibroids. And they tell the doctor, I didn't know. Or at the time of delivery, for example, you do a cesarean section, you're like, oh, there are some fibroid nodules around. So the most important thing we need to stress to these women is that, yes, fibroids could affect infertility, could cause infertility. But if these fibroids cause fertility issues, treatment is available that can help improve the odds of these women having children. And so we have to disabuse their minds about this myth. How are fibroids going to lead to infertility? We know that the fibroids, when they are healed, even though they are coming from the muscle layer, they could have adverse effects on the lining of the womb, the endometrium, where pregnancy comes to stay. Sometimes some of them may even obstruct the tube so that it will prevent the sperm from reaching the egg, or when she conceives, prevent the pregnancy from traveling back to stay in the lining of the womb. And that could be, some of them will also cause distortion in the endometrial cavity and atrophy in the endometrial lining, preventing implantation. And so we know they can have adverse effects on fertility, but we need to tell them that, look, there is help available if we see them early and manage them accordingly. The fifth myth is that fibroids, once I have fibroids, they are going to have surgery on me. In our sub-region, surgery is a big deal. The doctor taking you to theater, going to make a cut on your tummy to remove something. Previously, surgeries, because GA and other complications, a lot of them, some of them ended in death. But these days, things have become so simplified that we should tell these women that once you have fibroids, it doesn't mean that you're going to have surgery, because we have less invasive treatment methods that are available for managing these fibroids. And these are available, and so we should explore through research how best we can use these less invasive treatment methods to manage these women who are going to have fibroids, and that fibroids does not equate to surgery. Others also think that once I have fibroids and I'm going to have surgery, they are going to remove my womb. And that is another myth that we have to talk to these women about. Usually this is coming from traditional medical practitioners because they want to make sure they sell their medications effectively. In our society, we know that fibroid equals to, the uterus equates to intact womanhood. And so if somebody is going to take away my womb, then that is going to be the loss of my womanhood. And most of our women will not want to go through that. But we all know that hysterectomy may be the last resort if all other things do not work. And there are less invasive methods of conserving the uterus, even when you have to do surgery on these women. And so that is another myth that we have to talk to these women about during our interaction with these women. The seventh one is fibroids and cancer. We know that fibroids are tumors. And locally, in local parlance, if you say somebody has a tumor, thinking is that, the person has got cancer. But that is not the situation. We know that fibroids are benign growths and not linked to uterine cancer. Even though they adversely affect the quality of life, it doesn't mean that they are cancerous. Of course, the risk of cancer is there, but it's very small, less than 1 in 1,000 cases. Since practicing as an obstetrician gynecologist in UK, Ghana, I've not removed any fibroid nodule that the histology has come to say that this has cancer. And so we have to disabuse the minds of our women about this myth as well. Then the third myth is to do with traditional medicine helping to shrink these fibroids or dissolve these fibroids. This is something that is so pervasive in our environment. Those, apart from traditional doctors, these days we are seeing a lot of faith therapy, spiritual churches where patients will go and stay for a long period of time, supposedly having treatment from heavy menstrual loss and then from fibroids as well. What are the outcome of this long delay? These patients delay in presentation. So the fibroids are larger and complicated. The fibroids can be so large that they may even compress on the ureters, the tubes that drain urine from the kidney into the bladder. And they may even have complications pertaining to their kidneys as well. Once they delay, then obviously and become complicated, there will be increased cost of treatment to these women. that surgery is likely to also be more difficult, especially those who come in with recurrent fibroids. The surgeries are likely to be more extensive. Skin incisions, instead of giving a nice bikini incision so that she can still wear her bikini, we turn up giving an up and down incision, which may cosmetically be not good for these women. Of course, longer recovery, the effect of these large fibroids on the fallopian tubes. And the fibroids are complicated and huge. If you are not careful, you enter into the lining of the womb. The lining may heal, become fibrosed, and they end up with what we call Asherman syndrome. So all these are complications that can arise once these women delay in presentation. This is a good advert by one of our local people where it says, say no to operation. A patient showed this to me where she was taking 20 tablets in the morning, 20 afternoon, 20 in the evening. And I was asking her, so do you have space in your stomach to eat at all? She came back and finally we had to do surgery to remove these fibroids because they were complicated. So it's something that is pervasive in our environment and we need to talk about it. So it's not just knowing the myths, but how are we going to make sure we try and reduce or remove these myths from our women? Why do we have these myths in the first place? We don't have effective educational programs by healthcare professionals. I've spoken on some few occasions about fibroids, but it was just some group of women, church women fellowship groups, and then professional women groups that we went to have this discussion with. But hardly do we see this happening all over in the country. So it's something that we have to tackle when it comes to educational programs. So what are the solutions? One is education, and I'm happy Fibroid Foundation Africa is spearheading this. Education, education, education. Of course, we need advocacy, awareness education programs, and support groups. It's very, very important that this is done to make sure that we remove these myths that these women have and make sure we get them out of the grip of what is not scientific when it comes to fibroids. So probably this conference, I must say, may be the catalyst. It shouldn't end here, but we have to move on and get it done. Our women need our help. The second one is policy making. And usually these things, we have to lobby a lot of these are women parliamentarians, women in politics, because this is a women issue. If most of our countries, the women occupy a greater proportion of our populations, then their issues must be of paramount concern to us. And so national policies on uterine fibroids, very crucial, how they can access care, how we can get less expensive and effective and acceptable forms of treatment for these women, expertise when it comes to care, and then research into how we can prevent these women from getting these huge fibroids. So research is also very crucial. Without data and evidence, how can we effectively manage or educate these women? Interestingly, most of these research that have been done on fibroids, current and past, a greater proportion of them are not conducted in sub-Saharan Africa, where this condition is highly endemic. And so the onus lies on us that we collaborate and make sure we get the research running so that we can use evidence to be able to talk to these women. We know that at the end of the day, this will help reduce the colossal healthcare expenditure associated with uterine fibroids. It will have a significant positive impact on the health outcomes for these women and ultimately improve the quality of life of our women during their reproductive years. So in conclusion, fibroid has a huge burden on us. There's lack of adequate information on fibroids, and that is why there's making room for myths. These myths can be demystified, but we need research, advocacy, education, and policy making to be able to penetrate into the women group and get the change done. A collaborative, patient-oriented, cost-effective, and culturally sensitive approach must be at the forefront of this our endeavor. We should know that we shouldn't rest on our oars because this will help improve the quality of life, remove the negative social stigma, and reduce morbidity and mortality rates in our women who seek medical care with uterine fibroids. I thank you very much for this morning.
Thank you so much, Dr. Anand. Such an awesome and wonderful presentation. So at this time, it is time for our live Q&A session. And I don't see any other questions in the chat. And I see Dr. O'Handy's comments, which we certainly, I'm sure all of the presenters agree, and we will make haste and move upon this. But if you have questions, please put them in the chat. This is an awesome opportunity to get all of your questions answered and to make preparations to follow up on what Dr. O'Handy actually has put in the chat regarding action. So at this time, I'm going to turn it over to our Q&A moderator, Dr. Davison Muno-Duafa from Zimbabwe, and let him moderate the Q&A session. See, Dr. Muno-Duafa, you have to unmute yourself. Because I see he joined us. I'm not sure if he's having technical difficulties, but I'll keep monitoring the chat, and I guess we can start. And then once he comes online and makes himself visible as unmuted, then I can revert back to him. So in the interim, I see we have a comment from Constance Mandangenda. She also thought that we need a strategic document, yes, a roadmap to guide fibroid prevention and management efforts. So if anyone wants to comment on that, I believe she's following up with Dr. Elhandy's suggestions.
So actually, I have a question for you, Lillian. Like, how do you stay so up and perky, sore? I know you are in Ohio. Are you on East African time?
It's my large cup of green tea.
Really? That's another use for green tea. No, I mean, I'm really just very heartwarmed by all of these activities. It's just, I'm so happy with all what's happening. This is really almost like a dream come true. We've been talking about this for a long time with you and Liz and others. So it's just amazing to see it actually happening. So that's why I put all of, sorry about being so wordy and lengthy in the chat, but I hope maybe Lillian and I already cut and pasted in an actual like Word document. But yeah, I would really love for this to lead to something concrete, something sustainable that we can continue to build and work on, because this is so important. So I actually do have a question for my African colleague experts. It's kind of really interesting because everything we do with fibroid here in the US, it's always, okay, let's compare, you know, African American to European American to, you know, Hispanic American, things like that. So I still kind of trying to wrap my head around all what you see is actually African. Nothing else, no African something, just African. So it's interesting. But for example, we did a study here a couple of years ago. It's called Capture US. It's really like an observational kind of epidemiological study to see how gynecologists treat fibroid, what's the attitude from practitioners, from the actual patients, what kind of treatment are they getting offered, just that kind of study. So it was really interesting that we saw that African American typically gets offered procedures. They get from, okay, so from the provider side, or at least that's what the patient told us, that the providers offer them certain things. to treat their fibroid. And they said African-American was the majority, probably like 70-something%, they get offered surgery more, or the emphasis on surgery. While European American, it's actually the opposite, was 20-something. And there's more attempts to treat them, medically. So that's from the provider side, or what the patient told us the provider offered them. Now, when we ask the patient themselves, what do you actually want? And we give them, many options and so on. It turned out that actually African-American prefer non-surgical therapy. They like to try medication, while European American actually prefer procedure, kind of get it over with. So it was very ironic. It's almost like the opposite, the mirror image. So of course, in the discussion and kind of argument, let's say, around this was, okay, well, African American tends to present with more advanced disease, large fibroids, and so on. So maybe it makes sense to probably offer them surgical therapy, etc. Who knows the reason, but this is the reality. So I was wondering in our colleagues in Africa, what do you think? I know you probably have more homogeneous population, but do you see that your patients are more interested in surgical procedures or procedures in general, or if there is a reliable, safe, and effective medical therapy, that would be what they would like? What's your impression about that?
Yes, Dr. Anand, go ahead.
Oh, great. Thank you very much, Dr. Hindi. I think that we have a major issue when it comes to recommending surgery to these women, even those with very advanced and huge fibroids. Because once you mention surgery, the first usually question intervention is that, Doctor, can't I have anything to help shrink this fibroid? So most of them shy away from surgery. And there are cases where you offer surgery, they don't come back again. They come back later and the fibroids are worse. So the issue of surgery is something that deters a lot of these women from coming forward earlier on to seek help, or even subsequently. Just this morning, I had to do a surgery on a woman who has been running around, with fibroids because she thinks that, oh, Dr. Anand said surgery, no, it won't happen. I can seek help from elsewhere. And finally, today she had to come in, we booked her for the surgery. So surgery is something that scares most of our women. And so that is why there is the need to look at less invasive or non-surgical methods of trying to make sure we manage these fibroids, rather at a very early stage, because the cases that I show, the fibroids are so massive that you cannot say this woman should take these masses home. Obviously, surgery will have to become the outcome. So I agree with that point that most of them want to shy away from surgery, and the onus lies on us to make sure we can help them with less invasive. I'm sure that is why they resort to the traditional herbal people, because they promise them that, look, my medicine, no surgery, your fibroids will shrink or disappear. That would be my comment. Thank you.
Thank you.
Okay, and I see Dr. Yaboa there. Dr. Yaboa, I think you have a question, and then I see also Dr. Muno Dawapa. We can move to see if he will take over as the moderator. But go ahead, Dr. Yaboa.
Yeah, thank you very much, Lillian. As my senior colleague, Dr. Anand, said, in fact, we don't get it easy getting patients to the theater for surgery. We really have to talk to them till they come to realize there's no other way out for now. And, realizing she stands at the junction of life and death, then there's no way out. Then they agree with us and take them to the theater. So actually, the first question they mostly ask, is there no other way out? Medications or anything? And because unfortunately, we do not have other alternatives. The only alternative we normally go by is surgery. And so if we could have an alternate way, another way of dealing with this uterine fibroids, I think our women will greatly love it. Thank you.
Thank you.
Excellent point. And as someone who had and has again fibroids, I asked that same exact question when I went to my own gynecologist. You know, is there some type of non-surgical, way to deal with this? And so that particular OBGYN had recommended ulipristal acetate. And given I do a lot of reading and being a member of Dr. O'Handy's team, I know more probably than some women about ulipristal acetate. And also because I knew about green tea, EGCG, vitamin D, and some other agents that we've studied during our research meetings for Journal Club, I knew that I did not want to go the route of ulipristal acetate. So I totally understand and agree with what Dr. Yeboah is indicating. And I've had many conversations with Liz of Fibroid Foundation Africa, where women come to her and ask the same question. Is there something else that can be done besides surgery? So this is this conference is a wonderful opportunity to learn about non-surgical, alternatives to treat these tumors. So I see.
So Lillian, can I have a quick comment because it's related to the same issue? Yes. So it seems really that the attitude or the interest of African patients with fibroids really consistent with the African American, that they really want non-surgical therapy. Because when we presented this Capture US data, as you can imagine, some doctors start to be defensive and say, well, the patient, the African-American patients, actually, they are the one who come and ask for surgery. And I really don't know where's the disconnect, because when we ask the patient in an objective questionnaire, they fill it in the comfort of their homes, it's actually online and so on, they told us the opposite. So it seemed like there is a disconnect. Some practitioners feel they are doing what the patient wants, while the patient tell us they want something else. So clearly, there's a lot of education needed on both sides at this point. And to your point, Lillian, yes, I mean, a lot of it for those, at least for those practitioners who, always suggest surgery, hysterectomy, and so on. The patient, if the patient is empowered with knowledge that she knows the other options and have a good discussion with her provider, then I think the discussion will go in another direction. Otherwise, everybody will end up with the hysterectomy. And so.
Okay, so I see we have two hands. So we have Dr. Lepper, and then we'll move to Dr. Igboeli. And then I will, in the interim, see if I can reach Dr. Davidson, because I see he's raised his hand several times. So go ahead, Dr. Lepper. You're muted. You're actually muted, Dr. Lepper.
So I have a comment sort of and a question for everyone and my colleagues in Africa. I think that the comments about how patients are coming with very large fibroids, the option really is surgery at that time. And I think, Eamon, that's what happens in the United States too. So if women are still very frightened about coming in because they think they're going to get surgery, or there's myths, my question to the African colleagues is, how much or what is the public health kind of situation? Are you able to get out into the villages to see patients? I mean, I'm thinking, I live in Utah right now, which is in the western part of the United States. And the University of Utah Medical School is responsible for the health care of women in about 5 states out here. And what's very impressive to me is that the doctors from the university actually go out into small towns. They send the OB doctors out to do high-risk obstetrics. They send out surgeons. So maybe what we really need to do, in addition to taking care of patients in large medical centers, is to get out into villages. And I'd like to know what is available in Africa. Are you able to set up a system like that? Where, like if you were able to go into the rural areas with earlier treatments and maybe ultrasound to discover who has it, would that work? And is it a system that could be set up there? I don't know, but I'm just throwing that out as a question to you and a possible thing to discuss.
Okay, so any of our presenters can unmute, actually any of the African colleagues can unmute yourself, unless Dr. Igboele, you'd like to answer this question and then, or comment on this question in addition to your question you were going to ask.
Well, thank you. Thank you for this interesting day 2 presentations. To address Phyllis' question, definitely there are not too many centers in the African continent that actually go into the villages. And that is my point yesterday, that we see only very few patients compared to the large population of women burdened with fibroids who are in the villages. Majority of the population of women are in the villages, and we are not able to do this for several factors. There are no empowerment or encouragement, even from the establishment. No policies even exist for women, and that's where really I get very concerned, that their interests are not presented. They're seen as nobody in the environment. So the issues in Parliament, they discuss how to disburse monies among themselves, highly corrupt in their systems, and they don't care for the citizens in the system. So even if consultants or residents or nurses, which really I think nurses should be a part and parcel of this middle level intervention from our providers, should be able to go to the villages. They kind of set up what they call medical centers, which is actually medical centers in various communities, which can become very useful in propagating uterine fibroid advocacy. Nothing like that is done. No funding, no recognition that this system exists. It's just your own. You are on your own. And I believe that the economic powers of the African women denies them the opportunity to seek intervention for themselves. And I think something higher needs to be done. Policy implementation should be initiated to benefit these people. Advocacy, education. The radio is nothing. Actually, not too many people have the opportunity to listen to radio at different times to discuss these matters. So we need people on ground. We need people from the medical centers of cities to go into the villages to kind of work with the women and make them understand that this problem can be diagnosed early and can be treated early. They don't need surgery. And actually, I'm a big surgeon, but I don't like surgery. Women with a fibroid, because I think if they presented early, they should not have this option. There are other options, less invasive, less expensive, more amenable and acceptable to the people. However, like either Jude or Kofi stated, the myths there are just too much. The prayer houses, the non-Orthodox medical practitioners, the chemists by the roadside don't want to sell their medications all for money, but at the expense of the sufferings of the women. So I think this particular conference should begin to think about what Dr. Al-Hindi recommended. And I think we should form a consortium, an advocate, a driving force, so that we can start doing in our little ways. If we can get support from bigger countries like the United States, UK, Canada, and all other places to really address the problem, making African women look like they're nobody. I really believe there is a way we can contribute, even from the United States, to make a difference in the lives of women in Africa.
Excellent, excellent. I concur. So any of the other presenters or any of the African clinicians would like to comment? As I see Dr. Olutosin, I know Dr. Chente actually had mentioned prevalence, trying to diagnose prevalence by going into the community with a portable ultrasound machines, which, something is definitely needed, because access to care, there may be barriers to access to getting to these clinics that by going into the villages that can be overcome with the portability. Dr. Chale, let's see, I see Dr. Yaboa, any comments? We also have Tanya Hohenester from Tigovit from Germany. Anyone want to comment? Dr. Fofi?
Yeah, thank you very much, Lillian. I think Dr. Mboli has said it all, said a lot about it. Most of the time, we are chanced on being invited by a church group to speak about women issues. And then the doctor chooses to talk about fibroids. Otherwise, there's no other way that a women get to hear about it. And to be honest, if it dawns on you to talk about it, then you are on your own, just like my senior colleague earlier on said. There is currently no policy known to us and no such efforts. I thank God fibroid Aunt Lays has started something like that. Fibroid Foundation Africa has started something like that. I know it will move on from here. And more thinking should be, I have a question, Lillian, if you permit me. Now, we know that women of grand multiparity do not have uterine fibroids, most of them. Yesterday, I operated on a woman. She is para 7, she's giving birth to 7 children. Yesterday was the 7th birth. We opened up, we delivered the baby. There were 3 fibroid nodules. As a matter of fact, the woman did not come to the hospital because of the uterine fibroids. I just chanced on it, and because I chanced on it, I did not leave them. We removed them. But what I mean is, women with many pregnancies really come with fibroid-related issues. Now, what at all happens to a woman's body during pregnancy? And if scientifically we can create it in a non-pregnant woman, wouldn't that prevent the development of uterine fibroids? I'm just thinking and provoking thoughts, such that if we could research into that, and if there is some medication that can create that artificial environment in a non-pregnant women, in whom the system might well recognize as pregnant to prevent development of uterine fibroids, as we see in women with multiple or a lot of pregnancies, then I think it's another way out. I'm just provoking thoughts. Thank you.
It was quite a novel thought indeed. Let's see. So I see, okay, so Dr. Davison, I see Dr. Muno Duafa. Dr. Muno Duafa, are you ready to take over as the moderator? I see your hand. I don't know if you can unmute yourself.
Lillian, not exactly. You're doing a good job. I've been following the discussion, and I think you're doing a very good job. I would let you do that, but I just wanted to also make a comment.
Yes.
And highly thank my colleagues, the presenters, the clinicians who have brought the evidence to the front for some of us from the social behavioral aspect. I think for me, one of the challenges in Africa has to do with the time of reporting, the health-seeking behavior how do we get more people to come out and seek medical advice early before things have gone out of hand? And I think that is, to me, a challenge. The condition is less understood, but having had, say, young couples who are not able to get pregnant, and they start to find out what it is, then the doctor finally stumbles on this and makes this diagnosis. But I am not sure how we can sort of amplify our concerns and findings to the general public so that this is also taken in on board in terms of health-seeking behavior among young women or childbearing women. Thank you very much. Liliana, yeah, I do have a little challenge because sometimes I get a break and sometimes but I've tried to stay on. So I would let you run the Q&A for now. I'm really impressed by the way things have gone to this moment.
Okay, thank you, Dr. Muno Duafa. Yes, my friend from Zimbabwe. So I will continue to moderate. And so I will actually go back to something I asked yesterday, and then I will, I saw Dr. Prosper's hand. So when I asked my question about how does something, basically a community effort look like, where you have these global health workers, because really what it sounds like you all need, because Dr. Assam mentioned it, Dr. Anand mentioned it, Dr. Maingo mentioned it, is the education, the early education and going out into the community. We cannot wait for women to come to the clinics. So my thought is have a community health, a uterine fibroid community health worker force, where you have it's either nurses or trained community health workers going into the communities, just as Liz of Fibroid Foundation Africa is already doing, but it could be, modified across your respective nations, how you want to do it. But it would basically look like that, to get that education, to get that awareness out into the communities. So I think that would be a perfect avenue to really address what Dr. Muno Duafa has mentioned, and also, what Dr. Assam mentioned about the lack of community awareness, the lack of education. So, okay, and I'll turn this to Dr. Ohandi, and then over to Dr. Igboeli for his question. So go ahead, Dr. Ohandi.
Right, thanks a lot. So I have a couple of comments. So one, for Dr. Yubowa, comment about pregnancy. This is very true. From the epidemiology side, we know that high parity is a protective risk factor. Now, how does that work? And if we can develop a really kind of a realistic strategy, short of like encouraging women just to stay pregnant, I think that would have other, probably, I don't want to say catastrophic, but it will affect the economy in many different ways. But if we can mimic this in a therapeutic strategy, I don't, it's hard to kind of capture that now. But just to say that Donna Bird, I know her name was mentioned multiple times by Phyllis and so on. She's a wonderful epidemiologist, reproductive epidemiologist here in the U.S. from NIH, actually, in North Carolina, NIHS. And as you probably know, Lillian is doing her PhD in epidemiology. So I tell her, you're going to carry the baton after. You're going to be the next Donna Bird, I hope. So, but Donna did a wonderful study looking at women who have fibroid and followed the fibroid during pregnancy and then in the postpartum period by regular ultrasound. And she found that relatively small fibroid, 4 centimeters or less, they actually disappear in the postpartum period. They continue to exist. And then also this common kind of impression, I don't want to say myth, but impression that fibroid grow a lot in pregnancy. Some do, but actually most, they stay stable. So we kind of, even as a, I think as a medical student and a resident, I like, you know, I got that scare about like pregnant women with fibroid, that it's going to be catastrophic. Usually actually they stay stable, but then the small one, the 4 centimeter less, actually disappeared in Donna Bird's study in the postpartum period. So that's that observation. Now the mechanism, we don't know. In her discussion, she suggested maybe the remodeling that happens in the postpartum period, the huge, because obviously the uterus gets huge and much bigger. And then there's the involution during the 6 weeks after delivery. As the myometrium gets remodeled and so on, some of the moderate to small fibroid gets kind of refurbished or remodeled into a normal myometrium. But the real observation is they disappear based on the ultrasound. So, but the mechanism is not clear. Of course, some people think it's the ischemia, like as the severe contraction during labor deprive the fibroid from the blood supply. So it's almost like a physiologic kind of uterine artery embolization, if you wish. Some, you know, everybody can speculate about the mechanism, but of course the hormonal profile also during that time is crazy. Like estrogen, progesterone is so high, then it comes down dramatically after the placenta comes out. So that could be contributing, but until we know exactly what's happening, then it's hard to try to mimic this in a non-pregnant kind of environment, like Dr. Yupo suggests. It's a very good suggestion. Unfortunately, we don't fully understand the mechanism. Until then, we're going to have to wait. And then, Lillian, if I can, there was actually a question from Dr. Shante, kind of buried in the chat, almost like an hour ago. I think I managed to bury it with all my lengthy comments. Sorry, Dr. Shante. But she was asking, have you used the Tegovet green tea to treat women with uterine fibroids? If yes, in which indication, and what were your results? Great question. So I have to say, that's one of the nice things about these natural products. They are available. Obviously, I don't have any patent on green tea or vitamin D or any. These are natural products. You cannot even patent them. And clearly, I want to say I have absolutely no financial connections to Tegovet or any particular product. So yeah, no, the answer is no. I have not used Tegovet per se. We used just generic green tea extract from one of the nutritional companies here in the US, in Wisconsin. We used 800 milligram of EGCG. So my patients who wants to use green tea, I tell them, just go, obviously this is over the counter. You don't need a prescription for any of that, by green tea or vitamin D. I just tell them you have to get that particular dose, this particular amount of EGCG in your body. So you just read the label, calculate how, like what's the percent of the EGCG in your green tea formulation, and make sure you get 800 milligram in your body. So yes, I haven't used any particular product per se. Of course, if a product has the EGCG and it's working well and it's good quality, of course, by all means, but I have not used this particular one. And then my last comment, because I think the last speaker was saying he had this patient with huge fibroid all the way to the, to the diaphragm and all of that. And she was using, I think it looked like a green tea or so, and it didn't work. I mean, of course, like even the synthetic compounds that we just got FDA approval on, like, elagolix, ulagolix, and linzagolix is probably going to be approved soon. There's no 100% response rate. Nothing has 100% response rate. Surgery, and I'm a surgeon, as Dr. Igoboli said, you do a lot of fibroid and you feel good, of course, you're trying to help your patient. But if you do the myomectomy in a young patient, they're going to come back. It's 70% recurrence rate. So nothing is a cure, permanent cure, and so on. So we just try to do the best for our patients. But I just want to say, in our green tea study, that I described in my talk, we actually were inclusive. Like we didn't have any particular size limits in the inclusion, exclusion criteria and so on. But honestly, I think our patients are so smart. So we ended up with what you can consider mild to moderate disease. For example, the average hemoglobin in our patient population was around 9 to 10. So we didn't really get, by own choice, by own self-referral, if you wish. We did not have in the study those with severe anemia, those with those humongous fibroid, the 36 weeks fibroid uterus and so on. So surgery will always have a place, but we were just trying to make it more kind of a smart choice to limit surgery to those very severe cases that everything else has failed. That's kind of what we're trying to do. Right. Thank you.
Yes, so as a great segue, and I guess you can answer this as well as, I think, yes, she is. Tanya from Ticovit is also on the study. So Liz had asked this question as well a while ago. It says, will the fibroid grow again if you stop taking the green tea extract? So if you are, you can comment on that. And then if there's any questions for Tanya also from Ticovit. Oh, she's muted.
Sorry.
There you are.
Hi. So can you repeat the question because I just heard it now?
Yes, so this is actually for you, Dr. Ohandi, or for you. It says, will the fibroid grow again if you stop taking the green tea extract?
Well, you have to take a maintained doses, right? Because I took like 800 milligram daily, but you have to take a maintained doses. If it works and you have a shrinkage or the myoma stopped growing, so you can reduce it to a maintained doses. So it means maybe 1 capsule daily or every other day. And what I also did, I'm drinking also a lot of green tea, but a high quality. So if for some don't want to take any more the capsules, they can use, for example, green tea as to drink instead of coffee. And of course, to reduce the capsules daily, maybe 1 or every other. And if you have the feeling or the fibroids are growing again, so then you are increase the milligram of EGCG daily again. Right, Dr. Al-Hindi? So you do it the same?
Yeah, no, I agree. So I tell my patient, because I get a lot of referral for medical therapy of fibroid. So patients who don't want to have surgery end up, come to me. And still, I do a lot of surgery because there's just so many cases. But I tell them fibroid is a chronic disease. It's really like hypertension, like diabetes, like, it's not like a sore throat. You take antibiotic for a week and it's gone. It's not that kind of disease. It's a chronic disease. So medical therapy will work, and as long as you take it. But the way I kind of counsel my patient, and even in conferences and so on, so I always try to support my patient to kind of bridge into something. So for example, the perimenopausal women, and we know a lot of women, 10 years or so before menopause. So menopause average age in the US is about 52. So, from the early 40s, I'm sure you all see that. A lot of patients with fibroid, they start to have the heavy irregular bleeding and so on. But they start to have also menopausal symptoms, like some hot flashes, night sweats. If you measure their FSH, it's probably start to, creep into 15, 18, 20, and so on. So you know that they are approaching menopause. And of course, we know menopause will take care of fibroid because of the severe drop in estrogen and progesterone. So I use medical therapy as a bridge into menopause, and then the problem would be over. We just do too many hysterectomies. And by the way, I know from the surgeon point of view, hysterectomy is a great surgery, and it's a feel-good surgery because, okay, I cured the patient, but and also the patient feels good probably in the short term. But we have more and more literature now on the short and long-term complications of hysterectomy. short-term things like the, pelvic floor disorders, the vault prolapse, the, urinary incontinence, fecal incontinence, and so on. And we have known this for a long time. But the new thing relatively in the last few years, and we just published a major review article on this, the long-term complications. Women who had hysterectomies, even without bilateral salpingo-oophorectomy, even while preserving the ovary, they actually have long-term risk, increased risk of heart disease, of dementia, of stroke. I'm happy to share, actually I'll put the link in the chat right after this. So it's very clear that the hysterectomy itself, of course, the immediate reaction, okay, well, because you remove the ovaries and they become hypoestrogenic. No, this is actually hysterectomy without TSO. So something about the hysterectomy, maybe we don't know fully what the uterus really does. We think it's just the home for the baby, it pushes the baby out. Maybe it does more than that. But this is epidemiology. Again, back to Lillian, I tell her, epidemiologists around the world, you guys find these things, then we have to find the explanation. But this is the epidemiology. So this is a big group, the perimenopausal women. Also young women. I see a lot of, students at the University of Chicago who are busy with the school and so on. Minority women, minority young women, and they have severe problem with fibroid. And they're not even trying to get pregnant. They might not be even in a relationship, but they want to, of course, preserve their future fertility. So I think medical therapy is an excellent choice for that group to bridge them into pregnancy. Because as we heard multiple times, pregnancy is actually good for fibroid. The whole biology of the disease changed during pregnancy, after pregnancy. So I tell them, let's use this until, of course, on your own time, ready to get pregnant. Let's then evaluate your fibroid disease after the delivery, after postpartum and all of that, and see, because the disease might totally change. You might not have any more problems with fibroid and so on. So I use medical therapy as a bridge into pregnancy. And that's a huge sector, because if you do myomectomy on those young women in their mid-20s, late 20s, they're gonna keep coming back with more fibroid, more myomectomies. And pretty soon you're gonna have a frozen pelvis with lots of adhesions and all of this. And the story. So yes, I think, yes, you have to stay on the medical therapy for it to work, but you have certain stations, let's say, in your reproductive journey that can actually help you and improve your fibroid on its own,
Yes, so that's an excellent segue, Dr. O'Handy, because Liz had followed up to ask. So basically you're saying you have to live with green tea for the rest of your life, or some type of, non-hormonal maintenance, if that's what you choose, for the rest of your life.
Yeah, it's just like any other chronic disease. I mean, hypertension, patients take antihypertensive, they don't become part of their routine. They don't even think about it. Diabetics, many other chronic diseases, and if you need to take green tea every day, that's really not that bad. It has many other health benefits. Right. Or vitamin D or things like that.
Yes. Okay, so I see Dr. Egbaweli, or do you want me to go to Dr. Chente first? Okay, so Dr. Chente, go ahead and answer your question. Unmute yourself. There you are.
Okay, thank you, Lydia. So I'm so happy to listen about what Dr. Heyman have said, but it's so difficult. So how do you proceed to keep those women just with medical treatment? As we know, sometimes when you are using progesterone, by the time the progesterone also induce the augmentation of the fibroid, of the volume. So how do you manage to keep them when they are still young, and then maybe they are having the bleeding? How do you manage in your practice to keep them for so long without operation? Thank you.
Okay, I'm sorry, I lost you for a few seconds, but you're asking you know, so they are having heavy menstrual bleeding and fibroid. And how do you avoid surgery? Because the treatment is going to work. I mean, the medical treatment is going to decrease their bleeding. So they are not going to have to live with bleeding. I'm not saying they have to live with bleeding. I'm just saying they can continue to live with the medical therapy, because, for example, in the green tea study, the 6 months, we saw major improvement in the hemoglobin level, in the heavy menstrual bleeding was, you know, dramatically improved. We saw about almost 80% decrease in the amount of menstrual bleeding. So they've come back to normal, or even less than that, their pre-kind of treatment or pre-fibroid menses. So yeah, so they will improve. Their symptoms will improve, their quality of life will improve, as I showed you the data. So yeah, they don't have to live in suffering, they will actually improve. I think the only thing we're suggesting is they need to continue to take their medical treatment, whether it's the green tea or the vitamin D, or, you know, whatever other medical, maybe some of the FDA approved medical therapy. Right, so yeah, so the question was, well, how long, and if you stop the medical therapy, the symptoms will come back? Yes, the symptoms will gradually come back. But if you stay on the medication, whether the natural compound or other options, then you will actually get better. You will be, you will get rid of most of your symptoms.
Okay, thank you.
Sorry, I was sorry. I thought I was asking. So Dr. Ohani, this also is for you. It says, is there any contraceptive effect of the green tea? I don't know. I'm thinking this might be for you or Dr. Or Tanya from Tegovet.
No, I hope not, because we actually, the friend study that that Lillian mentioned yesterday, and I mentioned today, we are we are treating women with infertility. So no, I really don't there's absolutely no evidence. Of course, we did not do like the contraception study, like, you know, certain design if you want to do a contraceptive study. But absolutely, the effect on the endometrium that we tested and so on does not suggest that at all. In fact, like I said, the FRIEND study, so just briefly, so this is an NIH-funded study. It's ongoing. We still have about 3 years to go, so I don't have any data yet. But women with fibroid, as several of the speakers said, it's kind of associated with infertility. It's hard really to say fibroid cause infertility, because many women with fibroid can easily get pregnant on their own. So it's just an association. If you look at 100 women with fibroid, 100 women without fibroid, the women without fibroid will be much easier for them to get pregnant. But still, many women with fibroid get pregnant. So that's why it's called unexplained infertility with fibroid. So in that particular group, when you have a patient, everything is fine. The tubes is open, they're ovulating, the partner have normal semen count, but they still have been trying more than a year with no success. That's unexplained infertility. If they have fibroid, then it's called, the SRM still call it unexplained infertility, interestingly, but associated with fibroid. So what do we do in those cases? There's no clear algorithm, no clear guidelines. Some doctors do the myomectomy, some doctors do nothing, let them just keep trying. Some doctors do, you know, start to do ovulation stimulation, IUI, and some doctors even go straight to IVF. So because of that, there's no particular practice, standard of practice. So we are doing this study. So we're going to take women in this situation, and then we'll randomize them to green tea, 800 milligram every day for 3 months versus placebo. And then they will continue to try to get pregnant. And that's another advantage of these natural products, green tea, vitamin D, etc. They are fertility friendly, because all the other FDA approved hormonal therapy, they work by inhibiting your ovulation. So you cannot really try to get pregnant while you're using them. Things like, elagolix, linzagolix, olagolix, all these new FDA-approved medications. Well, linzagolix is not approved yet. So that's it. If you're trying to get pregnant with fibroid, you use this medication for 6 months, try to control your fibroid, then you stop them, then you try to get pregnant. So a lot of aerobics in a way, sort of like the Lupron story. But with green tea, they will continue to use it while they're trying to get pregnant. Those who get pregnant, of course, will follow them, safety and all of that. And those who don't get pregnant then will be offered ovulation stimulation and intrauterine insemination for up to 3 cycles, while actually using the green tea again, because it is safe and friendly with trying to get pregnant. So yeah, so that's the study. I don't have any data yet, but no, absolutely, I don't have any reason to think that EGCG is contraceptive, and I certainly hope not.
Go ahead, Dr. Igboel. Oh, did Tanya have a comment? And then we're coming to you, Dr. Igboel.
Well, I am agreeing with Dr. Al-Hindi. So EGCG works positive, if you want to get pregnant or for infertility, because EGCG works like reducing oxidative stress and any inflammation in the body. So mainly some women that can't get pregnant, we don't know why, because sometimes it's also the stress, the pollution, the food, anything, and also the mindset, so we don't know. But what green tea does, and several in vitro and vivo study has shown already, that it's reducing oxidative stress and preparing the body for a wish for a child. So also that the quality of the eggs getting better, and also for female and male. So I think it works for both good if you are wish for a child. So EGCG definitely is supporting for if you want to have a baby.
Okay, thank you, Tanya. So now we'll go to Dr. Igboeli, and then I will present Dr. Chale and Dr. Chente's question.
To address the issue of endometrial receptivity and conception with people who take green tea from Aaron Al-Hindi, I think we can actually incorporate further studies in your current arms of study, because the endometrium height, 8 millimeters and above, is more receptive, and there's a receptive window for conception and implantation. And I think we should use that as a guide, because we already have an ongoing study, and all we need to do is just add transvaginal ultrasound to look at the endometrium, and that endometrium can give us, information, which is an added information to kind of either beef up our current knowledge of green tea scenario. I really believe in what the last speaker said. Other things actually interfere with pregnancy: the mental status, emotional status, nutritional status. So if we just have to use only one parameter to judge pregnancy, conception, and implantation, I don't think it's correct. So I think we need to have all these things coming together, and then multiple factors actually promote pregnancy status. Okay, that is one thing we need to deal with. Then my own contribution in other areas, I go back to the reaching women advocacy education in the community, because I think really, if there's any one thing we have to take away from this conference, is strategy. We need to galvanize our efforts that we have gotten today and all the information, and put them together, like Dr. Al-Hindi said, and then formulate a what we call work in progress, WIP, and then move forward with it. But it requires a consultative effort. The Fibroid Foundation is also one element we have to really coin on to, so that they can, because they may have other things they're doing that we don't know, which we kind of help when we're trying to build up a policy, a strategic policy, how to reach out to the real people that require the services. The mid-level, you don't have to be a doctor to go and preach to a woman that there's need for you to present early if you have this kind of scenario. I think to demystify some of the issues, we can train people, actually health workers in communities. And I think that should be our most effective channel in reaching out a broader population of our countries in every African area, because they have local governments, they have community wards, they have local medical centers. These are avenues that we can harness in our approach. And then you see that referral system, triage, what we call triage system, will be much more effective. And I believe that some of the data we're getting from the medical centers, teaching hospitals, or some kind of my center, is actually in the bell curve, is a kind of a subset of something, which really, for me, may not be the true incidence or the true epidemiological presentation of this disease. We need to work a little more. And I really think all of us on this platform, plus whoever we can, that can listen to us, plus governments that don't listen. I'm not anti-government, but I don't think they have any good thing for women. And really feel that in Africa, women are still very marginalized. The window shows you see women becoming commissioner for this, still they don't have a voice. So I think there are other elements that are really very critical in trying to reach out to women. And if we can put up a strategy, a policy implementation that we can work with, so that the people who are trying to, so academic, what I've seen today, what this whole presentation, but it's an eye-opener for what can actually be done. Because the import of all this, how do you translate all this, our knowledge, to benefit the woman that really has the disease? Thank you.
Yes, thank you, Dr. Igboelim. So I believe this is, yes, this is for Dr. Handy. And I think you touched on this. Dr. Chale asked if the patient uses the green tea alone or in combination with the medication, if she has not had any complications yet. And I think in the FRIEND study, Dr. Handy, are we using Clomid, or did we say letrozole?
Okay, so yeah, again, very good question. Thank you, Dr. Shante. And well, in the study, when we were just trying to improve the symptoms or control the symptoms of fibroid, there was nothing else. It was just green tea. Okay. Of course, the patient, if they need contraception, they can use non-hormonal, barrier, copper IUD and so on. It's really, in my patient at least, I don't like to use any hormonal contraception for fibroid patients, because I think Dr. Shante herself said the progesterone actually make fibroid bigger and so on. So this is what we did. Now in the FRIEND, these women are trying to get pregnant. I don't think we need to mix the two studies, Lillian. So for women who just want to control their symptoms, improve their bleeding, improve their quality of life, we just use green tea alone. In women who have unexplained infertility and fibroid, the study, yes, we'll use green tea alone first, but those who are not going to get pregnant, then we'll use ovulation stimulation with Clomid. But this is in a study, so we don't know the outcome.
Okay, thank you. And then Dr. Chente asked, she said, to any gynecologist, how do you manage in your practice to reduce post-operative bleeding after myomectomy? Because we do use tourniquet per-operatively and sometimes post-op, and that the patient will start bleeding in the drain, even if the hemostasis was okay, per-operative. So this is to any gynecologist. How do you manage to reduce the post-operative bleeding after myomectomy?
You want somebody to answer this question?
Yes, this from Dr. Chente in Cameroon.
Actually, number one, there is nothing short of good surgery from the beginning. Okay, you have to achieve at the time you open up that the myometrium. That is when you start actually controlling the bleeding. Sometimes, for me, if I can get into the cervix, I can actually use a tourniquet to reduce bleeding intraoperatively. But immediately remove that particular tourniquet, you can see that there's a resurgence of revascularization of the vessels. And you actually know that you have done a crummy job if you see a lot of bleeding coming out at that point in time. The most important thing in controlling hemorrhage, intraoperative hemorrhage, postoperative hemorrhage, is to do a clean, good surgery from the start. And I impress upon all my surgeons that they have to take extra steps to ensure good control of hemorrhage, of good control surgical techniques to make sure that every little area inside that fibroid they have taken out. From the base, is very much obliterated and compressed so that they don't have any room to accumulate blood when you close the abdomen, because that is the issue. A lot of surgeries and repeat surgeries as a result of inappropriate surgical techniques. And really we need to do that. And sometimes we use a drug called transaminic acid. I don't know if you're aware of it. We use it for post-op bleeding in obstetrics. We can do that, but that is really not my choice. My choice is good operative technique from the onset.
Yeah, I agree with Dr. Igopoli. I actually don't have any solution for post-operative, but intraoperative, as Dr. Igopoli said, I also use a lot of vasopressin just locally. I just infiltrate, and I don't inject inside the fibroid, because the fibroid itself is really not that vascular. It's the capsule. It's around the fibroid. So I infiltrate a lot of vasopressin. Of course, I have to tell the anesthesiologist that I'm injecting this so she doesn't freak out. But but I infiltrate around the fibroid a lot of vasopressin, but that's intraoperative. It helps you see better and close better. But then, honestly, post-operative, if we have bleeding, that's a problem. So, I agree with Dr. Igopoli.
And I see that Dr. Olutosin sent a message to Dr. Chente also about what he does in Nigeria. Okay, so there's a comment there for you, Dr. Chente. And then I don't know if Dr. Fofi or Dr. Nan, Dr. Yeboah, Dr. Chale, any of the other surgeons had any comments to your question. Don't see anyone unmuting. Let's see. And then I believe actually Liz actually had a question. I don't know if your question was answered, Liz, if you can still hear me. Let's see. Unless maybe her question was answered. Okay. So I actually do have a question. So this is regarding vitamin D, because, you know, Dr. Ohandi had mentioned this, and I'm sure in some of the publications that you all have read, that vitamin D deficiency is a problem, or can be a problem in Africa because of the amount of sun exposure that you need to go through the melanin for the conversion in the body to use the correct form of vitamin D. So given that Dr. Ohandi's research has shown that there's this risk of uterine fibroid development if you are vitamin D deficient, I'd like to hear from the African colleagues regarding vitamin D as a possible supplement to study, in the clinical trial. I know Dr. Igweli has mentioned it in the call to action paper that he co-authored with Dr. Handes, but I'd like to hear from the other clinicians. If they're still with us. I see you there, but I don't see anyone unmuting. Oh, I see. Okay, so I see, okay, Dr. Fofi, go ahead.
Thank you very much. On the issue of vitamin D, that sounds like a huge opportunity for us, especially in Africa here, because for us, depending on the high load that we have, we look at a situation where we can have something that we can deploy easily among a greater population that will help to prevent. So with this in mind, at least we have some markers. So the first step is to be able to identify those that are of high risk. Then we can then go ahead to offer this, or even better still, suggesting this as a preventive for majority of the people that have fibroid already, and even those yet to have. So going further is about just having some guidelines on how to deploy that, and then we can look at providing some ways around it to let our people benefit from the full advantage that can be derived from such knowledge. So I think we'll be looking closely in that direction within the next days. Thank you.
Lillian, you're muted.
I'm muted. Sorry, I'm muted. So yes, thank you. So I was actually asking as a good segue about the EGCG, given, the presentation on the EGCG, would that be something that the clinicians are interested in trying as a possible clinical trial for uterine fibroids? Dr. Igboeli or anyone?
I think that our Handy can handle that question. Amen.
Yeah, I mean, we did the clinical trial in Nashville here in the U.S., as I mentioned in my talk. I just want to impress upon my colleagues again, and we have this discussion actually ongoing here in the U.S. as well, because for the first time we had 2 medications approved by the FDA for fibroid, first time ever in the history of fibroid. Even Lupron, by the way, was never approved for treatment, long-term treatment of fibroid. It was approved just as a preoperative adjuvant, just to decrease to improve the anemia and that kind of thing. But for the first time in June 2020, the first one was approved, elagolix. I'm using the chemical kind of name, not the commercial name. And then in June 2021, last summer, ulagolix with combination therapy was approved. And then the expectation is linzagolix will be approved this summer. And all the related papers, of course, has been published in the New England Journal and so on. So there's debate, okay, how does that work with the natural therapy and so on. So the studies have been done. The impression, again, back to my previous comment, this is, even though it's approved for all kind of fibroids and so on, and again, in our study, the EGCG study in Nashville, we had all comers, no size limitation of fibroid, no particular, location, etc., number of fibroid. I think the general feel in the field is this medical therapy would be great options for mild to moderate. So like any disease, the earlier you intervene, as Dr. Igoboli mentioned and others multiple times, the earlier you intervene, the better. Again, if you have somebody coming to the emergency room, hemoglobin of 4, she's hemorrhaging, fibroid 36 weeks, yes, you correct the anemia, take her to the OR. I don't think anybody is trying to convince you otherwise. But there are, millions of other women with early disease, mild to moderate, who can benefit from non-surgical therapy.
Right.
So yeah, so that's the idea. And it would be nice to actually do some studies in Africa to validate and make sure it works in other population. But I think a lot of data is out there.
Okay, thank you. Because I think today, Dr. O'Hanley, the only EGCG study that's been done on the African continent was that initial study in Egypt from Egyptian women. So there's a need to, to do a larger study in Africa, using the EGCG, and then, much larger studies with the vitamin D in Africa. There are some. I know there's the publication out of the DRC regarding vitamin D, but we definitely need the research on vitamin D deficiency in Africa.
Yeah, absolutely. Again, there's no evidence that fibroid biology is different in different populations, but we really didn't study it, and that's actually part of Lillian PhD study, is to compare the genetics of African fibroid compared to African American. So we'll find out more after that. But yes, it definitely would be helpful to confirm the same observations in different population, different location, and so on.
Yes.
So the reason actually I raised my hand, Lillian, but I think Phyllis and Liz has other comments. It's actually a totally different question, but I'll wait until this discussion is.
Okay, I think Liz had her hand raised. I think Phyllis was actually hand clapping for you for the drug you had mentioned. Go ahead.
Okay. Okay. We at Fibroid Foundation are privileged to use Tigovit. We had one patient, a very young lady, and we wanted to help in a different way to see if the Tigovit or the Tigovit green tea will work for her. And I must say that she has improved greatly. Recently, she went in for a scan, and the noodles had reduced, and also some of them had disappeared. There used to be more there, and even the doctor himself, the sonographer, was even surprised. So this is just one case. We don't know about others, but this is what we have tried in Ghana, and it really worked. So my challenge is that what are the cost elements? Because this one, we were able to get the Tigovit for free. It was sent to us directly. But if the patient had to buy it or procure it herself, what is the cost element? How expensive would that be to her pocket or the pocket of the family? So that is my only challenge, because we might be able to use it. And I have so many patients I want to try on, but looking at them, they cannot even afford. Then it means that the organization has to be supporting them, supplying them with that for quite some time, and it will be a burden on us. So I'm asking, what is the cost element when it comes to using green tea? Or how would it be packaged in a very simple way that it will not involve any much cost, maybe?
That's very good.
Well, I can reply to that. If Phyllis let me, right?
Yes, go ahead.
Okay, Tigovit is a very high quality of green tea. So why it's so, because in Germany it costs 90 capsule cost 37 euros. It's around, I think in dollars, $40, right? For 90 capsules. So it's around for 1.5 months. Why it's so expensive? Because I'm taking a high quality of green tea from an organic green tea cultivation in China. And what I have two different kind of extracts. I have one concentration of 60% EGCG and one with a lower concentration, because we found out that EGCG also needs other polyphenols. And in addition, we have combined it with pepper and vitamin C to increase the bioavailability, because EGCG is also a very sensitive molecule. And what we use, it's a very high quality of capsules as well. You know, it's a vegan capsules with, it's a high quality, but of course we can find a solution, you know, to just make a different packaging and an easy packaging for patients who cannot afford it. I'm very willing to do that. This is not a problem. So we can try to find a solution to offering in a different, you know, for people, for patients who doesn't have the money, let's say, to afford it. I can do that. I can look into it, and I'm like an easy packaging only with a little jar with not so much marketing, and yes, we can do that.
I think Phyllis has been waiting, Vivian.
Huh?
Yeah, I just wanted to make one comment. You know, we have really, as physicians, switched or beginning to switch the attitude from surgery to early treatment. And there's always going to be a case for surgery, we know that. But when we start talking about early treatment, we have to think about our infrastructure. You know, we can't do clinical studies, Lillian, if we don't have a good infrastructure.
Correct.
We can't recruit patients and talk to patients and stuff without a good infrastructure. And that's why I keep going back to what Dr. Icabelli said all the time about you got to get out into the communities. And so when you're looking at all these issues, you have to say, what are you going to do first? You know, and you have to have a plan. And I think, you know, you can't say to a surgeon whose job really is to take care of patients with really large fibroids and many fibroids, that's their skill, and they're still going to be needed to do that. But I think what I'd like to have this group think about a little bit is the challenge of what happens going forward. How do you work together? How do you get a group together to maybe have a white paper to have policy changes made? Because until you really do that, it's not going to be helpful to think about, oh, gee, let's go do this trial or that trial or whatever. I mean, you have a real job in Africa, I think, to really say, how are we going to collaborate? How are we going to work together? What kind of public health policies do we need to do? Do we need to get out in the villages to educate people? How can you get nurse midwives and nurses and the mid-level people involved in this issue? We can help you, but, you know, and I'm very sensitive about the fact that for a long time, developed countries were always thinking about, oh, gee, let's go to the parts of the world that don't have the same resources that we have so we can do clinical trials, and isn't that great and all that. And I'm very sensitive about that. What we really need to do is say, what do you want in Africa? What do you need in Africa? And how can we help you? How can we support you? But it's your decision, and you've got to come to grips with what you have to do. But the infrastructure has to be there, and you have to, that's an issue, you know? And so I just wanted to get us back a little bit more into what Al Hendy had talked about earlier, Eamon had talked about earlier, about where do we go from here? How can, you know, is it more meetings? Is it getting together to write a white paper? How can you think about collaborations? What are you going to do after this conference? We don't have much time left, but that's really what we have to do, I think. And other things will then fall into place. And I'm sorry, I'm sounding like I'm a big preacher, but we need to think about that, I think.
Yes, excellent point, Dr. Leopard. So I know Dr. Igueli had a comment. I saw him, he had a comment.
Actually, what Felix says is actually the bottom line. We need a strategy. I said it over and over again. It's good to sell all the products in the world to women with fibroids, but we as providers, we as the gatekeepers for these women, as the advocates for these women, we must have to have a plan. We have not developed that plan, and I'm not hearing it yet. But I think developing a white paper, a strategic policy, and who are going to be involved. It's not just doctors. If you ask Dr. Prosper to go out there, it will be difficult for me. But if I train a health worker in the various communities, and we can find them in everywhere, health, just pure training, and give them routine instructions. This is what we need to do to get to the populations, and this is what we want to deliver to them. You get more results very fast in all the countries in Africa, and it will give us more information.
Yes.
Into the epidemiology of even the incidence and prevalence of fibroid in the system. Because what we are seeing, all these big studies, I'm a professor in the university, and you know something, I always tell my students, including medical doctors, that because you are in a highly elevated institution, the university, a teaching hospital, does not make you see the realities in the village. So for us to move from where we are, the pyramid of this, into the grassroots, I need this information and how do we strategize policy, work in progress, and put things together so that actually, if we have to prevent fibroid from the grassroots, you see less presentations in the university teaching hospitals, and actually you see quite a drop in the magnitude of these black fibroids. You see some of us bring out, from the abdomen and say we've done something. We've done nothing in my book, because really we're only just trying to improve ourselves and tell people in the world that we are good surgeons. But those patients, if we catch them early, they don't need our services. And we'll be more famous doing that. Thank you.
And so to segue to your point, again, this is what the Fibroid Foundation Africa, what Liz is doing there, the grassroots on the ground, in the community, in the villages, on the radio, going to the markets, talking to the women. This is what is critical because, as Dr. Anand and many of the presenters indicated, there's so many myths that keep these women hidden. So if you see another woman coming, another woman who can tell you, I'm a sufferer, another woman who can speak to that woman's fears and talk to her and give her some education information, then I think you will be more successful. And I see Liz's hand and also Dr.
Yes. Yes, sorry. Yes, and Dr. Igueli, please. This is the reason why I yearned so much for this conference to take place.
Thank you. And
I would say a big thank you to Dr. Leopard, because without such a conference, it's definitely difficult to tell the world the magnitude of, or to share with the world the burden of fibroid in Africa. Right. But with this, with the voices that we have put together on this platform, I don't know the person who would turn his back against any statement or anything that will come out of this conference. So just be patient. It's going to be an action time, and all of you will be needed to bring your input here and there for us to put a paper together, and not a paper that will be lying in anybody's office, but a paper that we are sharing with the whole world, with the leadership of this continent, and anywhere it can go. So just exercise patient. It is not going to be just talk, and we leave here. We've started from somewhere, and I believe we've come this far, and it's not going to end here. So be assured that something good will come out of this deliberation or meeting. Thank you.
Dr. Fofi.
Yes, thank you very much. Yes, just to walk the talk from the programmatic perspective, I see it this way. If we can come out with a prototype program so that we look at it from a program approach, what are the potential ways of screening? So early screening and the preventive approaches that are possible. If we can have something documented based on the best of evidence available for countries to follow or adopt, then we begin to reduce the burden, because all the techniques, novel ones in the world, we don't have access to them. But we should be able to have access to the low cost interventions that are proven to be cost effective, that we can have access to. These are the ones we can deploy in the villages, in all the areas. So yes, there are quite a number of things that have been said that are fascinating, but can we crystallize them into specific points in a programmatic approach for any country who want to adopt and consider, so that we use that as a roadmap or a flow chart, so that we can consider and work with it within the next few years, and we'll have amazing programs coming up, and we'll begin to really walk the talk. Thank you.
Yes, exactly. So any other comments? Dr. Chale, I see Dr. Yaboa there, even any of our attendees. I see some attendees. Okay, Dr. Yaboa.
Yeah, thank you, Lillian. I stand to say we all stand hand in hand to support Fibroid Foundation Africa. And they've started championing it, and we stand by to help in any way that we have to. If we have to give a talk, if we have to operate, whatever, we stand to support them in any way. We are in a way locked up in the hospitals, and we don't get the chance to step out as many as we would have wished, because the hospital will be left vacant as well. So if they have the opportunity to step out, we are ready to respond to any call that they place at us to achieve what we all want to achieve. Something good will come out of it. Fibroid Foundation Africa, thank you and congratulations.
Thank you.
Thank you.
Excellent, thank you. Thank you, Dr. Yaboa. Let's see, I see some Jane O'Malley Oku. I think, or maybe she's just connecting to audio. I don't know if she has a question. I don't see her hand raised. Let's see. Dr. Morton, you're quiet there. Any question? As Phyllis said, we're coming to the end, or we might be over our Q&A, but I did not want to end without giving everyone a chance to have final comments.
I'll just say thank you. I really enjoyed listening all morning, starting at 4 a.m. And it was a pleasure to learn the depth and breadth of what activities could be planned.
Yes, yes. Thank you. I don't see any other. So I will make sure I save this file, save the chat file. We do have the recording. So that way we can do just as Dr. Handy, Dr. Fofi, Liz, Dr. Igboeli, all of the clinicians have indicated that we need to have the paper, the discussion continued. And then I will also follow up with a follow-up email, of what exactly is our next task. Do we set a meeting, a virtual meeting to have the roundtable? I know Dr. Igboeli had mentioned we need a Uterine Fibroids Africa roundtable. And as Dr. O'Handy indicated, a Uterine Fibroids Africa task force. So that will be likely probably our next steps as to getting that underway. What does that look like, even if we have to have multiple committees within those entities. So with that, I don't see, I'm doing one last scan. I don't see any other questions. So with that, I'm going to turn this over to Liz from Fibroid Foundation Africa to have our concluding remarks.
All right. Thank you very much, Lillian. And thank you for good work done. At long last, we have come to the end of this thought-provoking discussions on fibroids. And I believe, and you all agree with me, is that it's been a far-reaching and eye-opening discussion. And I'm very, very grateful to all of you. It is obvious that, and I gather from the clinicians across the continent, that there is a high burden of fibroid in Africa, yet it is understudied, underreported, leading to lack of data and lack of interventions towards the prevention, or maybe elimination, which I personally believe it is possible from what I learned from the use of green tea and other natural remedies. In fact, this conference marks the beginning of an emerging partnership and an intercontinental collaboration to drive more attention on the disease. It has been emphasized by all our distinguished speakers that there is the need for action in the form of comprehensive strategies to include public education, awareness creation initiatives, as well as expansive research, policy change, and funding to tackle this debilitating disease. Fibroid Foundation Africa needed a conference of this nature to be a springboard for detailed intervention. And I assure you that our technical team will work with all of you to put together a position statement with some key recommendations and share with all the key authorities responsible for health across the African continent. On behalf of the planning team, I wish to say a big thank you to our speakers, the sponsors, and all our partners, especially Campion Fund, who welcomed the idea for making this conference possible. We are so, so grateful, and I promise you, it will not end here. It will never end here. Again, I wish to say thank you and have a good weekend. Thank you.